Okay, good afternoon, everybody. Welcome to the meeting in public of the board for the St George's Epsom St Helier Hospital Trust and University Group. We're going to start today with some feedback on visits to services that members of the board have made here at Queen Mary's in Roehampton. We're having our meeting today. So, according to my cunning script here, Lizzie, Michael, Andrew, Natalie, and possibly others went to the Douglas Bader Rehab Unit and the Vitali Clinic and associated services. Is that right? And did you agree who would provide a summary feedback?
No, we really failed on that.
Very clever, Natalie. So we visited a range of different very specialist services within the area. So we visited the Vitali Clinic, which deals with patients with spasticity. They're very busy on Mondays and Wednesdays. It's a Thursday, so it was there wasn't much going on in there, but the service is fabulous in terms of what they provide. And then we went to the gym focused on supporting amputees, and again that was really impressive. I've been there before, but the sort of services that are provided here are really state of the art, very focused on the needs of patients with significant challenges. So it was really good to see that in action. And then we went to the rehab ward, that is a fabulous space, with a beautiful garden that they tend as part of the occupational therapy sessions they run. They've got a range of different types of patients on the ward, including patients who've had amputations and patients with functional neurological disease, so patients who haven't established a physical cause for their neurological deficit, so it's felt to be mainly psychological, but who have significant impairment. So it was really impressive, and we looked at some of the schedules. There's a lot of activity going on for these patients from a range of different therapies, and it was really good. The two big things they wanted to feedback, one was significant issues with patient transport, which seems to have got worse recently. Transport not coming, not being suitable for the type of patients who often have big sized wheelchairs, and so transport's turned up and not been able to take the patient. And they had a significant event recently with a patient waiting over 2 hours for transport that didn't come, who then ended up in some difficulty. And the other thing they flagged for us was they were running a virtual service for patients with functional neurological disease that, as part of the SIP program, was cut. And so there isn't a service for those patients now, apart from them coming into the hospital. So it's basically lengthened the wait for care. And obviously we got one side of the picture, but it's something we felt we should take away just to have a look into, to see what's gone on, what was the decision making, what don't we know about that, and maybe some lessons learned from the quality impact assessment that was done as well.
Thank you, Andrew, very much. There's a few things. I guess, Kate, you'll have got those and can... Brilliant. Thank you very much indeed. So, Vic, Richard, Leonie and Pankaj, I think you went to the prosthetics and orthotics department and factory. The factory is brilliant. I've been there before, actually. It's absolutely brilliant.
Yeah,
Richard,
sure.
please.
I'll do a bit briefly. So for anyone who doesn't recall the difference or doesn't know the difference, so we were reminded orthotics is devices fitted on the outside to make things straight. If you like etymology from the Greek orthos for straight, and prosthetics is added additional things like additional limbs. And we were shown around by Nick around the laboratory, which is or the workshop, which is a really inspiring place to go around, actually. I think some of the things to pick out, I've been there before, and I remember hearing in the past, and we talked about it again this time, the challenges of retention and recruitment. The factory employs both clinicians and technicians, and some of the technicians have been there for a very, very long time. So we met one gentleman who said he started when he was 16 and now he's 63, looked extremely cheerful and was making some amazing fittings for a patient who'd had quite radical pelvic surgery, and explained what he was doing. But Nick was saying that young people tend not to go into the highly technical jobs nowadays, and so there's quite a high turnover of younger clinicians, and the technicians are a group of extremely experienced and dedicated people who it's hard to see what the next generation of technicians will look like. But anyway, they showed us some of the things that they're making for patients, and the factory is making patient-specific molded fittings, orthotic fittings and prosthetics for the people that we look after here. The service is outsourced, and I think in many ways that helps it to run very smoothly and takes some of the risk away from us, but it also creates its own different kinds of issues and challenges. The lab is really a mixture of cutting-edge modern technology and some bits and pieces, including an old Singer sewing machine that's well over a century years old, but still perfectly fit for purpose. Probably the main thing that they told us, we also heard the story as we began the visit that Andrew was telling about about oversight in the transport lounge. But the main thing we heard in the laboratory was that it isn't climate controlled, and that's more than just a comfort issue. So when it gets very hot, some of the chemical processes that we do with the resins there just won't work because the resin won't flow properly, or you get setting problems. And one of the technicians was showing us how different layers of the resin orthotic can split and become separate if they're made at the wrong temperature. So there have been times when they've had to close down production because the temperatures are so high. When we were there, it's 32 degrees, but it feels very warm and very humid. So from a staff comfort point of view as well, that's far from ideal. And in the plaster room, there's a lot of plaster in the air as well. So issues around air changing and temperature and staff comfort and chemical stability were things they flagged from our state's point of view. But overall, an extremely positive visit and very inspiring and very unique. I don't think there's anywhere else in the NHS where you can see something quite like that. So the other thing I should say is we went to the rehab gym, and we met a patient who was very happy to talk to us, who was a quadruple amputee, having lost all 4 limbs through sepsis, but was very clear about how much support and help she'd had, and inspiringly upbeat and positive about things. So that was quite a moment, at least for me. Thank you.
Thank you very much, Richard. It's not just a brilliant and unique service, it's also one that's been there several generations, right? It's a amazing story. The history is an amazing story, actually. Good. Alex, Steve, Bidesh, Phil, did a combination of you go to something called the Gate Lab?
We went to the Gate Lab.
Are you going to explain what the Gate Lab is?
That was the first question I asked when we walked in, because it wasn't immediately obvious as you walked into this room. So it is about one's gait, and it's about people, patients who are struggling with their gait. They might be patients who have come from one of the places already described. So they get patients referred from other places here, and mainly referred from St George's. They might have had strokes, and which might cause them then to sort of trip up more. And so this is an idea of improving gait. And there's 2 ways they do it, basically. One is to look at the person's gait and then recommend and refer them on for surgery or some other treatment. And that is something where it's quite a complicated thing to do. They have cameras and they walk, and then they use the data from the cameras to then work out what is the best treatment. Then they refer them back to the surgeon or whoever's referred them here in the first place. They see 1 or 2 patients a week doing that. Then the other thing is if you can use I think it's called electro something or other, but they tie a pad to your thigh or your whatever, and that gives, small pulses and allows you to then walk more easily. And there was a patient trialing one of those as we were in there. I spoke to actually the guy afterwards at the big thank you, and the patient was extremely pleased, took the thing that he was using home and was going to come back in 2 weeks to see how he's getting on. And they see about I got the numbers wrong, I think about a dozen or so a week of those patients. So it's quite small numbers. It's a very small team. There are 3 or 4 people in there generally. They are medical scientists, the people who work in there, sometimes physios, but generally they're medical scientists. And there are 2.8 medical scientists who work here. And the sort of things that they mentioned are they've slowly ended up with a smaller teams. Like one of them, the guy we were talking to, Tom, has gone down to 80%, but the 20% has never been refilled, sort of thing. And those are sort of things. So it's the people issue, and also the kit. Interesting, the cameras are 25 years old, which is sort of, they didn't look like they were 25 years old, to be honest. And but if they had the state-of-the-art kit, they could then deal with the data much quicker, because the data will be dealt with by software which was modern, while the software is all 25 years old as well. So the scientists are spending a lot of time after the patient has left, sort of going through all the data to make sure that they get the right answers. Interestingly, there are only 12 labs like that in the country. There are 3 in London, and the rest are north of London. So they get some referrals from other places, but most of the referrals come from the people who know they're there, which are in St George's.
Very good. Thank you very much indeed. Matt, Kate, Yin, I couldn't come with you, but I think you went to Mary Seacole ward. Yin.
I did. I think I've been nominated, I think, to feedback, but I'm sure everyone else will be chipping in. So it was Matt, Kate, Teresa, and Karen who came along to the Mary Seacole ward, and we met Anita, who's the ward manager. We also met Johnny, who's the therapist, and quite a few doctors and quite a few nurses as well. So we met lots of people. So it is a rehab ward, and it's primarily to improve patients' ability to care for themselves following acute hospital stays, and normally from either St George's or from Kingston and some other local hospitals. So it's a 36-bed ward. I think 1 bay with 6 beds currently closed at the moment. It was a nice space, and there's quite a nice outdoor area as well. No age restriction to patients' admissions, although I think most of them are over the age of 65 years old. The average length of stay, and Kate will correct me if I got this wrong, is about 28 days, I think. In terms of contact with the acute hospitals, I think there's no problems. There's referral through iClip, and then the forms will sort of come through, so they were content with that. In terms of the 2 things that they wanted us to feed back to the board was one around difficulties with social care, because until social care is put in place, they can't be discharged. So that's a bit of a barrier. And then the second thing is around psychological support. A lot of patients, when they are at George's, would have access to psychological support, but as soon as they come over to QMH, the psychological support ceases. So they wanted to know whether it's possible to have access to that. That said, they are having, I think they are doing an audit of some sort to be able to provide some better data around their need. So I'm going to stop there. I'm sure I've missed lots of other things.
Okay, thanks very much, Yin. Great. Just to say, for anybody who wondered where the CEO and the deputy CEO went just now on the camera, they went to get some chairs for some new colleagues who joined the meeting. The role and job of the CEO and the deputy CEO is very, very varied, I observe. Thank you very much.
No hierarchies.
Thank you. Okay, great. Really interesting set of visits as always. Nicola, could I just ask you if you wouldn't mind please passing on our thanks to your colleagues. I think it's your colleagues who arranged the visits again, and we really, really appreciate them. Thank you. Okay, so opening the formal board meeting in public. Welcome everybody. A particular welcome to Nicola and Teresa, who are covering for Elaine, the Group Chief Nursing Officer. You're very, very welcome. Welcome also to members of the Inclusion Board, Karen and Dee, who are here with Amy, who runs the Inclusion Board for us. And also welcome to governors, Dimpner and Shuli and Alfredo, who are here, and John was here earlier as well. And welcome also to others, members of the public and others who are observing today. We have some formal apologies from Mark Bagnall, the Group Chief Officer for Facilities, Infrastructure and Environment, from Elaine, as I mentioned, and from Thurza Sawtell. I just also want to record in public, this is the last meeting for 3 of our acting or interim colleagues, Lizzie Alabaster, who's been acting as the Group Chief Finance Officer, Elaine Clancy, who I mentioned, and Alex Shaw, the Acting Managing Director of Epsom St Helier. Thank you again very much indeed for your contribution, both in your substantive roles and also stepping up as members of the board, and we wish you all the best for the future. Are there any new declarations of interest? Very good. Are we happy to approve the minutes of the meeting we held on the 8th of May? Ian.
Just one little correction. I was also part of the group which attended emergency department. My name's not there.
Ah, okay. Very good. We'll correct that. Thank you, Ian. Any other corrections? Okay. Action log. Steve, would you mind taking us through this? The first item relates to basically recurrent and non-recurrent SIP information, which I think is now integrated into the month 2 integrated finance report, which we're dealing with at item 3.2. So we can close that action. Have I got that?
Yeah, that's right. We can close that one.
Okay.
The next one is around mandatory training. Came out of a discussion about freedom to speak up training for staff and the differences between the 2 trusts. There's a broader review of mass training going on. I don't know whether Vic would like to give an update.
Yes, the national review of mandatory and statutory training has been going on for some time, and it is very near completion. I hope to be able to bring something through our governance by November latest, and we have been making good progress on aligning across the group. We're now just in the final discussions about how our resus training and our fire safety training should be delivered, just because the 2 trusts have slightly different models for these important interventions, and I think it's good and right that we give the teams who run them now time to really decide what's going to be best for the group as they integrate, because it's part of their wider integration work. So yeah, apologies, it's been on the action list for some considerable time, but we are making progress.
Okay, great. So we'll have a substantive discussion of this in November, and bearing in mind there's a lot of activity and therefore quite high cost in this area, and one of the questions is, are the benefits always worth the cost we incur? And that's what the national review has been looking at, right? So looking forward to that. Thank you very much, Vic. Next one.
And then the final one of these is about the embedding of all of our systems and functions and processes to support whistleblowing and freedom to speak up across the organisation, and when they'll be embedded. That came out of the board's initial discussion about interstitial lung disease. We'll be touching on some of that as part of the agenda later on. And then more broadly around how does the group embed speaking up more generally. That's been embedded into the St George's CQC well-led action plan to be a group-wide action plan when we hear back in terms of the Epsom St Helier well-led, and we're developing a group-wide freedom to speak up strategy, which will come through in the autumn.
Thank you, Steve. Any comments on the update on the action log? Okay, thanks very much. So our next agenda item is the interstitial lung disease, and extremely important issue. And we're going to invite you, Richard, as the CMO, to lead us through the discussion. So please, over to you.
Thank you, Mark. So the last time that we discussed this in detail in public board was back in November 2024. And colleagues will remember that at that stage, we knew that we had had a doctor a consultant in the respiratory department at St Helier who had not kept up with best practice in the management of interstitial lung disease. And we were commissioning an external review from the Royal College of Physicians to give a objective external viewpoint on how much harm that may have caused and what the learning was from that story. And now we have the report, and I think, to cut to the key point here, it's a very hard and upsetting read. As we go through this report and we read about the sample of 28 clinical cases that the independent panel that the Royal College of Physicians assembled, scrutinised, and you can see a couple of paragraphs on every one of those cases. And originally they were going to look at 28 and 2 fell out for technical reasons. But looking at the other 28 cases, the college judged how much harm had been done through poor care and judged that 7 of those 28 had suffered moderate harm, but 12 patients had suffered severe harm from poor care, and 3 patients potentially had a premature death because the care had been poor. So I wanted to open here by offering my apology as the Group Chief Medical Officer to all the patients and the bereaved families for this failure. I have been an acute physician for just about the whole of my career, and I've looked after many patients as a non-specialist, as a general physician with interstitial lung disease. And it is a very challenging condition, a cruel condition in many ways. And in the cases described here, most of these patients had a type of ILD called interstitial pulmonary fibrosis, in which the lungs gradually get more stiff, less good at exchanging oxygen and oxygenating the blood, and it's a progressive disease for which there is no cure. And until a few years ago, the life expectancy, according to the best informed research from diagnosis to death, was only about 3 to 3.5 years. But things change, and over the last 10 years or so, there have been new therapies and new and more well-defined approaches to looking after patients, new standards and new treatments. And 10 years ago, a drug called nintedanib was approved by NICE, and 8 years ago, a drug called pirfenidone. They're anti-fibrotic medications. They're not a cure. They don't help every person with ILD, but in a subset of patients who are eligible, they can slow disease progression. And in addition, there are very clear guidelines now around the care of ILD so that it's done in a multidisciplinary way, and so that no one person is making all the decisions about a patient, but decision-making and recommendations with the patient are made collectively. And any patient and any family, but particularly those with such a difficult condition, should be able to trust their doctor. And they should be able to trust the healthcare organisation that they're going to. And in this case, we're very clear that our patients have been let down, our families have been let down. And again, I'm very sorry about that. The way in which care fell well short of what it should have been was essentially that many of our patients were not offered these new antifibrotic medications when they might have slowed disease progression. Also, many of our patients were not referred by this doctor to the multidisciplinary team meeting, the MDT, in a timely way, or indeed not referred at all. And they were receiving recommendations and treatments that were not evidence-based, and in some cases receiving recommendations that are probably actively dangerous, such as not to have vaccination against influenza or COVID in the context of lungs that are already very damaged and people who are very vulnerable. So maybe it's helpful if we just think about what we knew back in 2024 and why we commissioned the Royal College of Physicians. So we knew back in 2024 that this doctor had not given good care. We knew of some cases that we'd looked into very carefully because either there had been complaints from the family or the patient, or because there had been Datix incident reports about poor care. So we had some examples that we knew about and we'd been open with our patients about in which care had been poor, but we didn't have a big picture overall. And I don't want us to lose sight of this, that our first priority when we started to realize the scale of this was to make sure that all the patients who were still with us with interstitial lung disease were being looked after safely. And just to remind the board and to reiterate the assurance, the board did hear the assurance back in November 2024 that we had gone through all our ILD patients' treatments, and if patients needed a course correction for their treatment, they got that course correction. And as we recalled our patients and corrected their treatment, what we certainly intended to do, what I think in most cases we did do, but it's not quite the same as giving absolute firm assurance, was to be really clear with those patients about what had gone wrong and what we were correcting. But what we didn't have was a really clear sense of the degree of harm that had been caused overall. And for that we needed externality. And we went to the RCP because they're well known for doing very good invited reviews. I would just like to say as an aside, I've commissioned quite a few reviews in my time as a Chief Medical Officer from different Royal Colleges, and I think the RCP has done a superb job and given us a really, really clear report, and I'm very grateful to them. But we commissioned the RCP to try and help us with the answer as to how much harm this had done and how much more we should be doing to look into things and be transparent and open with our patients and our relatives, depending on how much harm we think might have been done. And the Royal College advised that they would do that by doing a sample. They don't normally sample as many as 28 or 30, but in this case they did, and of course that took some time. And the outcome you see here in the attached report, which is extremely sobering. And the sample that the RCP looked at was weighted towards those cases where we already had concerns. The RCP said, share with us the anonymized notes of all the patients that you're particularly concerned about in terms of their care. This is both patients who were still living and patients who'd already died. But the RCP said, let's have a random element to this as well, because you're trying to get an overall picture. And so they said, give us 10 notes out of all the notes of ILD patients that this doctor looked after, give us 10 notes that are selected at random. So not at random in the sense that they were looked after by this doctor and the diagnosis was ILD, but otherwise random. Even within those random 10, there are instances of moderate and severe harm. So we got the report back in March, the final report. We got a draft report back in September. We got the final report from the RCP back in March. We thought it was really important that every single patient whose care had been scrutinized by the RCP, or if the patient was no longer alive, every family got a personal letter from me to tell them what the RCP had found. And we have now done that. And as I speak about this in the public domain now, all of those patients or bereaved families have received a letter from me with the relevant section of this report that's now in the public domain, telling them what the RCP thought. I've had a little bit of feedback, not from a large number of people, but I've had a bit of feedback from some patients and some families. I have to say, all courteous, all very measured, but leaving me in no doubt whatsoever as to how devastating it is to hear that kind of news. And a number of patients and families, bereaved, next to kin, have written to me in very clear terms telling me how awful this has been for them. So I don't want, there's a lot of information in this report, but I don't want to lose sight of that human aspect of things. We took the time, whether rightly or wrongly, I mean, there's no right or wrong way of doing this, but we thought it was right to make phone calls to all our patients and families first before putting a letter through the letterbox. So we did that. We offered everybody the opportunity to come and talk to us if they'd like to discuss in more detail what the RCP findings were. And everybody who we spoke to has said thank you very much, and we might or we will take you up on the offer, but we'd like to see the whole report first, please. So we've gone with what people would wish. The back in November 2024, I wrote to all the patients who were looked after by this doctor with interstitial lung disease from 2019 until this doctor was stopped by us from working in the organisation. I wrote to them all to say that we'd commissioned the RCP report, and I wrote to them all back in November 24 to say that we'll share that report with you when it comes through. I've written to them all again to point out how they can access this report. But one of the things that we have to recognise, seeing what the RCP found, is that the RCP has only looked at a sample of patients with interstitial lung disease, and we now feel obliged to look at the entirety of the ILD patients, the care that was given to ILD patients from 2019 until this doctor stopped working. Now, we have looked, and the paper perhaps slightly exhaustively, but I just wanted to be very clear about it. We have looked at the care that everybody received before, but the main point of that first internal review was to identify all our current patients with ILD and make sure they were being correctly and safely treated now, which, as I said, we did back in 2024. But of course, a significant proportion of those patients were already deceased by 2024. So it is possible that there are families who haven't yet heard that the care that we gave to their loved one who's since passed away was poor and may have shortened their life or given them a less good experience, worsened their experience of their illness. So out of transparency and out of a moral duty to be open, but also out of a statutory duty to be candid when we've caused moderate or severe harm through anybody's poor care, we're now committed to reviewing all the care based on, and it's very important that we have this, based on the methodology that the RCP has used. And we will review all those cases. We will use the same terminology as the RCP used. We'll categorize our harm judgments in the same way. Because what I need to be able to tell the board and tell our patients and families and the public is that we've been completely transparent about this, that we have discharged our duty to be transparent and open with everybody, and that we've discharged our statutory duty of candour. And at the moment, what I can say is what we know we have shared, where we have a duty of candour and we know we do, we've discharged it, but we know that we have to do this work. And again, I want to apologise to patients and particularly to families who've lost patients to ILD, because I can't say definitively now, today, here, how long this review will take. We very much hope that we can get it all done within the year. I have been cautious when I've written to families, and I've said that it may take us between 1 to 2 years. And I think waiting for, knowing that that information is going to come, but knowing it may not come for 1 to 2 years, cannot be anything other than a very stressful experience for people, and I'm very sorry. But we have to do it. We will do our very best to get it done between 6 months and a year. And my colleagues now have the tools to do that and are preparing to do that. And we've tested out some of the design and the methodology of that based on the RCP report. There isn't an awful lot more that I want to say as a voiceover to the paper because most things are laid out in the paper, but I did want to pick out a few more things. It's obviously really important that people should know that we've taken steps to make our respiratory service safe, and the paper sets out very clearly what the recommendations were of the Royal College of Physicians, and sets out, I think, very clearly what we've done so far to meet those recommendations. We've accepted all of them. We've acted on all of them. Most of them we've acted on fully. Some of them are still ongoing. It's all called out here. The board will want to know, and our public will want to know, our patients will want to know, where's the evidence that the respiratory department now is safe? And again, this paper presents some of that evidence, which has previously been to our quality committee, but it's a really important question that I think has to be answered here. And we have a program of ongoing audit to make sure that the service does remain safe. To finish up, the other things I wanted to touch on. We asked the RCP, because we felt that we hadn't done this as well as we should have done, we asked the RCP to give their judgment as to how well we'd done or not done in listening to concerns when they were first raised, and in responding quickly enough and effectively enough. And we were very honest with the RCP that we thought we hadn't done this as well as we should have done. It seemed fairly obvious to us that we had not done that as well as we should have done. And the RCP has said, and you can see in the report, that between 2018 and 2022, there were missed opportunities to respond in a more decisive way. And again, I'm extremely sorry about that, as I think I've said in a board meeting before. There is some really important learning for us here about how we encourage people to be able to speak up when things are wrong with healthcare, and how we look after our whistleblowers. The previous group chief nurse and I met with one of our whistleblowers a couple of times to hear their perspective on this story. I've met with a number of whistleblowers, a number of whom are still working with us, but there's one whistleblower who doesn't work with us anymore, and actually didn't really feel that they could carry on because the whole process of seeing poor care and living through that and trying to blow the whistle on it had been very difficult for them. The last thing that we want as an organisation is that people who have the courage to blow the whistle when they see poor care around them then feel, rightly or wrongly, for whatever reason, feel sufficiently uncomfortable that they don't feel they can carry on working here. That is a really bad outcome. And we need to be doing more to protect our whistleblowers. It is easy as a board and as a CMO to say nobody will suffer detriment for making a disclosure about poor care. I can give that commitment that I won't subject anyone to detriment for doing that. But making sure that whistleblowers are genuinely looked after and nurtured and listened to and responded to and not made to feel uncomfortable in whatever particular environment in the organisation they're in, that is harder, and that requires more work from us and more reflection. I think there's quite a lot in the paper about what we've done within the respiratory department, but I think there are lessons across the organisation. So part of the paper is about what we've done to try and strengthen people's ability to speak up. But people will not speak up about poor care for two reasons. One is that they think they might be punished for it, but the other is that they don't believe the organisation will listen or do anything. I very much hope that this paper and the publication of this report and what I'm saying in board now and our discussion that follows will help to show people how seriously we do take concerns. This I think is very clear that we have taken this concern exceedingly seriously, even if we didn't pick it up as quickly and as effectively as we should have done right at the beginning. And the last thing, and I won't talk much about this, but it may come out in the discussion, is it would be right for me and for the board to be asked, and for the board to ask me, how do we know that there aren't any other doctors in this organisation who are giving such poor care that they're harming patients, and we're not recognising it, or maybe it's locally being recognised, but that's not being heard and responded to. And there are some, to turn that really important challenge into some tractable next steps requires some focus on some key areas. And the RCP report itself picks out the importance of clinicians not making decisions on their own, but making them, and of course it goes without saying they should be making their decisions with patients, but also making them with the scrutiny collectively with other clinicians in multidisciplinary team meetings. That's a standard of care in many areas of medicine now. And so in some detail in the paper, we've talked about what we're doing to strengthen our oversight and the quality of our multidisciplinary team meetings across the gesh group and our morbidity and mortality meetings. These are meetings in which clinicians, not just doctors, nurses and AHPs and doctors, come together collectively to look at the quality of care. They should be key drivers of the quality of care, but they're also, they have the potential to highlight examples where doctors are disengaging or giving poor care without proper oversight. So there's a great deal of learning for us. So clearly, this is a step on the journey that we have the RCP report, and we've been able to share it with all the patients and families. But it's only one step in the journey, and there's a lot more to do. I'll stop there.
Okay, Richard, thank you. And I'm going to open it up for questions and comments from the board in a minute. But Matt, is there anything you want to say first?
Yeah, I just think on behalf of all of us, we should absolutely apologise to all the patients and families that have been involved. It's really an awful read when you read the report. I think there's a lot of common themes with other cases that have existed around the country about how clinicians can get isolated in their decision making. What Richard said at the end around multidisciplinary teams, etc., is a standard of care. We shouldn't have anyone who's autonomously making decisions without any kind of oversight or peer review. And that's an area which I think ourselves and other areas of the NHS really need to improve and tighten so this doesn't happen. The other thing I would say is around colleague relationships. These type of things don't happen when colleague relationships are really strong and functional and work well. And I think there's something for us to do about how do we create the right environments that those relationships work and can flourish rather than sometimes break down, as can happen in any team. But in this case, the consequences are significant and severe, as we've seen in this report. So again, I just wanted to apologise as the chief exec, but on behalf of all of us, to the patients and families involved.
Okay, thank you. So I'm going to open it up for questions, comments from board members now. Andrew.
Yeah, I echo everything that's been said. My question specifically, Richard, is around the time frame. So we talked about a time frame of 1 to 2 years potentially to review the remaining ILD patients, but there's other cohorts of patients that we're planning to look at. What's the time frame for that? Because the implication is if we review those cohorts and find a significant number where there's been harm, we may need to expand those reviews. Getting an early understanding of what resource might be required to do that would be really helpful. So I just wondered if we're clear on what the time frame would be.
I think we'll take them one at a time, Richard. So could you respond on that?
Yeah, sure. Thank you. And I didn't talk about sampling other patients looked after by this doctor. It's in the paper, but other patients who did not have ILD. My 1 to 2 years comment was really about the entirety of the reviewing. As I say, we'll try very, very hard to get it all done within 1 year. There is no particular reason why it should take longer to review the sample of patients who did not have ILD than it should take to review the ILD patients. We do have to have a process of selecting them. I won't go into all the details that's in the paper. You ask about resource, Andrew, and we do have the resource in that we now have 5 clinicians who are doctors, consultants, with the right skills and specialty knowledge, who are willing to help with this review. And so that resource is here. That's all sorted out. We don't want those reviews to be purely medical. The RCP review team was not purely medical. And care should be multidisciplinary. So at the moment we're identifying some non-doctor clinicians, almost certainly senior nurses, who will be helping with the review. So I don't think, although we will need to resource it, I don't think resourcing is a problem. I think the challenge is really clinician time, because even if we are asking these clinicians to do this in additional time that we resource, they still have a day job, and the day job is really important. And that's why I'm not able to be very definitive about how long it will take.
Okay, thank you. Others? Okay. So the first thing I want to say is just to reinforce what both Richard and Matt have said. It's a shocking and quite sobering saga, actually, and it's really, really important to reinforce and reiterate the collective apology. We're really, really very sorry as an organisation that this has happened in our organisation, and we want to do everything we can to recover from it and make sure we never suffer these kinds of problems again. And that's something that's very important for us all to be saying in the light of what's happened. I just wanted to check Richard, whether there's anything you want to say here about the position in respect of the doctor.
Yes, again, it's in the report. We stopped the doctor from working when it became clear what the scale of the concerns was. And that was in January 2023. So this doctor did not see any patients after January 2023. The doctor hasn't been employed with us since April 2023. We referred the doctor to the General Medical Council. If a doctor goes on to get a new job somewhere else, then the responsible officer of the previous organisation has a duty to share any concerns with the responsible officer of the next organisation. But it was very clear, given the magnitude of the concerns here, that we should also share the concerns with the regulator, with the GMC. And we did so. We made a formal referral to the GMC. But also because, to the best of my knowledge, the doctor has not gone on to work anywhere else. And on the GMC website, it says that this doctor does not have a designated body, which one could take to infer that the doctor is not working. It was necessary that the GMC would oversee the information that we could not share with the next responsible officer. The GMC registration conditions are in the public domain. The GMC registers in the public domain. The doctor has restrictions on their practice, cannot work, is not permitted to work by the GMC, except under very close supervision, and cannot work at all in an acute setting. The GMC is still investigating. It's not for me to say what will come out of that investigation, but it is our role to assist with the investigation with all the information that the GMC may want. And the GMC has asked for information, and we have shared it, and will continue to fully cooperate with their work on that.
Okay, thank you. I just want to take the board now through the remaining things that are our responsibility. And you've all read there's an enormous amount of paper here. You've all read it carefully. I just want to check your level of satisfaction on the forward programme of things we're doing. So the first question is whether you think we can take reasonable assurance that everything that's been done on communications with patients and families is the right programme of work. Are we happy with that? Okay. The next issue is the one Andrew raised, actually, whether we can, whether we're happy with the set of things we have set in place that's in the report and that Richard has described about the next steps to identify further possible instances of harm in relation potentially both to interstitial lung disease, but in relation potentially to other things the doctor was doing as well. Are we happy with that programme of work? So we can take reasonable assurance about that. Okay. Are we happy that the recommendations from the Royal College of Physicians have been or are being acted upon? Do we have a reasonable assurance about that? Okay. Are we happy that respiratory services at Epsom St Helier Trust are now safe? Are we reasonably assured about that? Yeah. Okay. Next, really important question, which Richard was right to emphasise. Are we happy that the steps that are being taken are the right steps to enable staff across the group to know they'll be supported if they speak up when they see something that is that they're concerned about? Andrew, yeah.
Well, I think we've outlined the right steps. It's something I think we probably all remain concerned about, and something that I think we need to really carefully continue to monitor. It's definitely something in People Committee we look at, isn't it, Ian?
So would it be fair to say we have some assurance on that, but we would like more assurance on as Steve? Yeah, go ahead.
Yeah, I mean, I think we may want to conclude that we've got partial assurance on that, insofar as if we're thinking about our speak-up arrangements across the group more generally, rather than in response within the respiratory service, we know there are challenges that we've got to address. We know that the CQC well-led report for St George's identified areas where we need to improve. So I think partial
is more, yeah. Okay, fine. That relates actually to the last point as well, about our level of assurance about steps being taken to get earlier detection, essentially, of any clinicians who are departing from safe practice. What level of assurance do you think we have on that? Partial or reasonable, or?
I'd say partial.
Yeah, Matt.
I would agree with partial. I think this is an issue for us as a group of hospitals, but I think it's also an issue as an NHS, because I think that the things that we find here and the learnings we find are also manifest in many hospitals. And I think there is something around the structure of how we work, how we get our teams to work, and that interaction in order to strengthen those processes. So there's something about which is unique to us, and there's something which is broader, and I'd say it's partial.
Okay, all right. So there's important follow-up on both those last two points then. Okay, Richard, thank you to you, but also many of your colleagues have been involved in sorting all this out. So thank you very much indeed for everybody's time and effort and commitment to doing that. The next item is in relation to water safety in the E block at St Helier Hospital. Alex, no, actually, Matt, I think you may have one or two things to say before we ask Alex to speak to the paper. So over to you.
Yeah, so thank you very much, Mark. So I just wanted to say a few comments. So this will be the pattern of how we put reports into the public domain. So we will have some time in the private board, and then the following month we will put things into the public domain as we have done today. That is absolutely to be transparent with our local councils, politicians, our own staff, and other interested parties that want to know more. So we'll get into the rhythm of putting these things in the public domain in this way. To be really clear, we have not made any decisions about the what and the where of how we deal with water safety on the St Helier site in maternity and other services which are in E-Block. We're working through a number of difficult things, the risk which we're carrying in that building and how best to mitigate it with the best solution for patients on that site. We've always operated on a principle that if we can keep our colleagues in the building they're currently in and do the remedial works safely, we will. If we can keep services on the St Helier site, that would be our preference. And only if those can't be met would we look elsewhere at where services can be positioned. We have not made any decision on that. This is our workings out, which we're sharing in public in what is a difficult situation, and we'll continue to brief everyone around that. But I just wanted to re-emphasize that because everyone goes to the end conclusion of what will be. We have not made a decision on how we deal with this at the moment, and we'll brief at the next board around the next steps of the decision making and evidence that we've got to put forward. And Alex, you're going to give some of the detail of the paper.
Yeah, thank you, Matt. I'll try to come off the back of that. So, I guess to start off with, just to provide some reassurance at the moment about where we stand. So, we are assured that the services within the E-Block remain safe today. That position is in the paper, but it's supported by mitigations that we put in place following expert advice. And again, we're releasing the two specific bits of expert advice that we've had. But some of the key parts are the enhanced surveillance, the microbiological monitoring, the point of use filters on the taps, changes and improvements we've made to the water infrastructure, including starting to dose the water that's coming into the building, and strengthening the governance for our water safety group. However, as you'll see in the paper, those mitigations manage the current risk, but they don't remove the underlying issue. And the advice that we've received is clear that the point of use filters should be considered a short-term measure and that a long-term solution is required. And that long-term solution is the replacement of the ageing water pipe work. What we're trying to work through, and just following on from what Matt said, this work is all about trying to prioritise the safety of our patients, families and staff, and represents a critical safety risk for the organisation. The challenge of completing that work in the building in E-Block isn't straightforward. A lot of the pipe work is embedded within the fabric of the building. The exact routes of some of that pipe work are not fully known, and there are additional complexities in what is quite an old building, 1940s construction, including asbestos. We've therefore concluded, and a lot of work's gone into it, particularly across our site teams, that the refurbishment work can't be safely undertaken while services continue to operate from the building. However, we also recognise that is a really important decision and we need to really fully test that. So we're also seeking some independent further review on that and what could be possible where the building remains in operation. But it also means that we're looking for planning for the temporary relocation of the E-Block services to allow for the replacement of the water pipe work to take place. As Matt said, our first priority and overriding principle is to explore options to retain the services on the St Helier site wherever possible. Clearly, this would be the best option for us, for our patients, for our staff, for our local communities, and for the organisation. those of you that will have seen eBlock will recognise that is a significant challenge. It accommodates a large number of complex clinical services. It takes up a big footprint. When you go and see it, it looks like a small hospital. And a number of the particularly inpatient services, maternity and neonates, have really important clinical dependencies, which means that they need to be housed together. So therefore, we're reviewing a range of options, including use of the existing estate, modular solutions, and then following that, if necessary, we'd be looking to work with system partners to understand whether some of the services could be relocated at alternative locations. As Matt said, no final decisions have been made on the future locations, and all of those options need further detailed assessment, and that really needs to include clinical safety, patient access, health inequality, impact assessments, implications for our workforce, and also whether it can be delivered operationally and the timelines for it. We've spent a lot of time talking with our teams, and I think I just wanted to flag and recognise the significance of this issue for our patients, our communities, and also our colleagues. Also, just to flag and recognise and acknowledge the exceptional work of our teams, particularly our maternity services, who've gone through a real journey over the last couple of years and recently achieved good across all domains in the CQC inspection. So it's been a real turnaround, and something that our staff, the organisation and our local communities are really proud of. So this is not an easy thing to work through, but it is really important that we take the right measures to deal with this critical safety issue. As a result of that, and probably the final bit I just flag, we've taken the decision to engage with our colleagues early and the staff that work in eBlock, even though we don't yet have all of the answers, and that's a conscious decision that we've taken as SLT Group Exec and through the board. We think that being transparent about the challenge and involving our staff in developing the solutions is the right approach. But the flip side of that is understandably that's not having all of the answers when meeting with the teams has led to a certain amount of anxiety that we're trying to support the teams with. But we feel, one, it's important to be transparent, and two, we genuinely want to involve our staff in finding the best solutions and trying to find the safest option for the long-term sustainable service, but also the least worst option over the short term. So I'll pause there.
Okay, Alex, thanks very much. Andrew.
Yeah, I think the approach we're taking now is really helpful. I think there have been some mixed messages, and I think being clear now that we're genuinely exploring all the options is really helpful and the right way to do it. There's risks with any of the options, not just safety risks. So that's why we need to go through a process to properly assess them. Some of the feedback we've had from members of staff and from MPs has been really helpful. And I think as we go through the process and look at the options, getting as much feedback as possible and really listening to what people are saying is going to help us make the right decision. So, yeah, I'm happy with where we are now.
Okay, good points. Thank you, Leonie.
I just wanted to just get absolute clarity, because clearly the verbal presentation we've had today is slightly at odds with the papers that are written. And so it was really to have absolute clarity that our thinking has sort of moved on slightly, and that the verbal presentation definitely, because the paper states slightly different emphases to what we've actually heard now. So just to be absolutely clear that verbally what we're all hearing is our direction of travel.
Yeah, Matt, why don't you, thank you, Leonie, why don't you?
Yeah, it's always tricky when you're trying to put a paper in the public domain, which is 1 month behind where you're trying to make the decision, and then and also it's a rapid pace thing where we're getting new information. So I think the verbal feedback that we've given is the actuality, which will be minuted in the minutes, of which we'll no doubt be held to account to. So I think that's what we'd like to say. I think we'll never quite keep up to speed in paper terms versus what's actually happening in this one. But what we say at the board will be exactly what we mean. But for transparency of colleagues and the public who will want to look at these, at least they will have the retrospect last month's paper to see where we were at that period, that point in time.
Okay. Ian.
Yeah, I was pleased to see that in terms of liaising with service users representatives, you are intending to establish an advice line for patients to sort of ring through, and then there's been quite a lot of FAQs for the healthcare staff based in block. In terms of continuing to brief them with the information that's upcoming, I understand that you will be having a series of similar events. Are you
Yeah, we meet every fortnight, and Alex has been leading that. Myself and Michael have also attended, and we plan to continue that over the next period to just give the staff and get their ideas and feedback, but also tell them where we're up to in terms of evidence and advice that we've got at that time. And there is an advice line which colleagues have helpfully set up for women who are going to be concerned, because they'll hear things in the press that may or may not be the actuality, but we need to reassure them and talk to them about exactly what's happening.
Let me just say one other thing about this. This is it's a big service, and there's a real problem. We do not. Let me just confirm that this is right. We do not, on our own, have the wherewithal, the money, or the other things to guarantee a solution to this problem. We're going to need help from other people. The costs, apart from anything else, in whatever solution we adopt, are going to be substantial, and so. Others are going to have to be drawn into to the solution to this program. That's a fair thing to say, is it?
Yeah, but both from temporary moves and from potentially significant funding of the building and the remediation, given our capital envelope and what we potentially are going to have to pay for this building, of which we'll make plain and apparent and transparent as we get that and we present the next papers to the board. So that's right. And it's also not in the gift of this organisation to make any permanent change to these type of services, which are directly commissioned by the ICB. So, and the last point just to make is there is no master plan here for us as an individual group of hospitals to reconfigure maternity services. We have an issue, we have to deal with it, and that may lead to short-term change, but we're trying to avoid as much of that as possible, and we'll give our workings as we move through.
Right. So there's an important difference between this and the last issue we discussed, which was largely for us to resolve and solve. It is a different thing, and I think it's quite important that everybody understands that, because that's one of the reasons this is so complex and difficult, and we don't have instant answers to all the questions that are being put to us. Okay. As you all know, to be continued. So next we're going to move on, Matt, to your Chief Exec's report.
So thank you for that. So just a few points for me. Really delighted. Obviously, we've just heard some really difficult. We'll just discuss some difficult things around water safety and infrastructure on the St Helier site. So it's really pleasing that we have managed to get some funding for the ED there, which we all recognise is so needed. Over 100,000 people attend that ED every year, and they are currently subject to very high conditions in really poor working space, and it's long overdue. So that's a very pleasing thing to have happened. We also welcomed the Secretary of State onto the St George's site last week, where we were talking about AI and AVT. We're the first region in Southwest London to have regional-wide ambient voice technology implemented, which I think is a really positive thing, should improve clinician-patient interactions and hopefully maybe even avoid some burnout of our clinicians using our EPR system. So I think that's a very positive thing. Just on the topic of what I discussed with the Secretary of State in private, I did talk with him about the water safety issues on the St Helier site and the need for urgent investment within that site. And we also talked about mental health patients within ED, bearing in mind all our sites and all our EDs having high numbers of patients with mental health disorders, which is the worst environment for them to be in. It's the most, the busiest, the environment just does not help them in relation to the conditions which they suffer, and that calm serenity which you need when you're in crisis. ED is the worst environment for that, as well as the effect on patients and staff and violence which we're seeing in the ED. So I did talk to the Secretary of State about that in detail, and telling him that the two majors that we had at St George's on one day a couple of weeks ago, one of those majors was completely full of patients in mental health crisis, and that is not a sustainable position, both to reduce corridor care, but also those patients are not being treated in the way that we would really want them to be treated. And so on all fronts, we have to change that situation, and we're doing work with that with our local mental health trust, and we'll be doing work with the ICB. In relation to this week, there's been some celebrations and the big thank you, which the Sun has come out for. You get very little in the NHS other than after 25 years, a pin badge and a certificate. So a cheap ice cream and a curry is a great way of rewarding staff for all the efforts and work they put in for us. We've done that on every major hospital site. We've had a bus going around community sites. We've had hundreds of thousands of meals served every day and we was some really great feedback from staff, and actually it's well deserved. And thank you to the charities for supporting us with that. And hopefully staff feel, one, we care, two, they feel valued, and three, we recognise it's really hot in our hospitals with no air conditioning, and some of our clinics have been running at 33, 34 degrees, which is entirely unacceptable, which links back to the first point about St Helier water safety and infrastructure. We were also pleased that we brought together our leadership forum, which hasn't met in well over 6 months. This brings together all leaders across our organisations, and we'll be doing that on a quarterly basis, looking at the priorities. We discussed in the last one our priorities as a group of hospitals, and we also talked about decision making and accountability and how we can improve that, with Steve leading a working group on clarifying that. So we have better decision making, more empowered managers, and everybody knows what they're doing at whatever level. So it was a good afternoon event in an air conditioned room, which is great. I'll stop there.
Great, thank you. I do particularly want to pick up your point about the EDs. It's really, really hard in EDs at the moment, and I just want to, I mean, we've said this before in private meetings, but the performance in particular of the St George's ED has been absolutely fabulous. Every week I get from Jim Mackey, a league table providing us with feedback on what's going on in lots of services, and really colleagues in the EDs, not least, but in particular at St George's, have done an amazing job over the recent past, in, as Matt says, really, really difficult circumstances. So thank you very much indeed to everybody who's been part of that. It's an amazing, it really is an amazing effort and contribution. I think you said thank you to the charities, so the big thank you as well. I just wanted to reiterate that, because no one should think that we're using the NHS budget to buy ice creams for staff. That is not what's happening. It's our charities who are enabling us to do that. Other comments? Oh, sorry.
Could I just make a comment on the STHED, because recognising that they've struggled with a bit around performance in compared to St George's, but you only have to look at the infrastructure there and what they have to deal with to recognise why that's so difficult, and the mismatch between demand of patients versus size of the ED. And the team have done a brilliant job of completely reconfiguring the pathway in ED, which is showing dividends and bearing fruit in terms of improved performance. And we've tried something, it did lead to a decrease in performance, but the error here is not trying to improve it. And I think they've done a really good job, and we can see that improvement. So well done to them too.
Yeah, thanks, Matt. That's really, really important. Thank you. Other comments, questions for Matt Yin?
Thanks, Matt, and thanks, Mark. In terms of the CQC well-led inspection, and I see that it's going to be expected in the coming months. Is there any sort of emerging findings that you might be able to share at this stage, or not, please? Thank you.
This is the STH full report from the visit they made in, when was it? May.
Yeah. So nothing over and above the verbal feedback which they gave me at the time, which was actually very positive. And I know, and many of the things which they discovered at the St George's well-led, they really recognised we try to change or improved in between that inspection and the STH inspection. So I think that was very positive. I'm sure there'll be some themes around risk. I'm sure there'll be some things around how do we have governance flows that really work. There'll be definitely things that the board are already talking about around culture, D&I, all of the things that we know we need to make improvements on. But nothing else has come forward, no letters of enforcement action, and we're not expecting any. So we'll wait for the report, I think.
Okay, thanks. Pankaj.
Matt, we've had a long-standing issue around discharge into social care. Well, what kind of conversations are we having with stakeholders to try and progress that as much as possible?
Yeah. And Kate, I don't know if you want to talk about Wandsworth and Merton now. I think that would be a good one to talk about. And it's different in the North of our sector, of course, than in the South. So Kate, do you want to come in now?
Yeah, no, happily to pick that up. We actually have good relationships with our local authorities, but they do suffer from shortage of funds as well. But we're now moving much more into neighbourhood ways of working. I'm the place exec lead for Wandsworth, and we work obviously very closely with Merton as well, and Sutton and other boroughs across southwest London. And we are looking currently at how we can support early left shift opportunity, including how can we get people out of hospital more quickly, particularly when they need low level packages of care. Certainly in Wandsworth, some investments going into that to have a sort of quick start option, so we're not waiting for other companies to come up with options. So I do think we're making some more progress in that space. It is a constant issue. I think where we see longer delays is around care homes and nursing homes. Obviously, a lot of care homes are privately managed, so it's negotiating. And when we're seeing complexity of patients increasing, of course, that is made worse by people spending too long in hospital. So a lot of the work we're doing is to try and stop people coming into hospital at all if they don't need to, delivering that care in a home setting, which is better for the patients, or indeed shortening the amount of time they are in hospital so they're not deconditioning. So I think there's lots going on. There are definitely, I can see some investment improvement happening through the neighbourhood work, but we generally have good relationships and are working that through as a provider alliance across all of the systems in South West London.
This is also an area of real strength at the Epsom St Helier Trust. I don't know if you want to add anything to that, Alex, because some of the national leading models are integrated care, which is big support to the discharge challenge, right?
Yeah, it is. And over the last year, in both the Surrey end and the Sutton end, we've set up a new transfer of care hub model, so supporting discharge. We've gone through and really assigned called KPIs against different pathways, P1, P2, P3, depending what level of support people want for discharges. And we've also actually cheapied on the Sutton end, cheapied across a number of our staff, our discharge coordinators on the wards. We've transferred into the transfer of care team under the community team, which has been really positive as well. So we're trying to bed those in. I think agreeing those key KPIs across the different partners was really helpful as well. And then on the Surrey end, over the last few years, we've been really developing the frailty model. And again, we think that is really beneficial model where we've got lots of our frailty consultants actually providing care in the community and trying to admission avoid, but also support people staying out in the community after discharge. We're just doing a trial at the moment of consistently providing that level of cover over 7 days. At the moment, it's inconsistent. It's about 4 days a week we have the full cover, and we're hoping that the results of that trial will support us to really make the case to have that consistent cover, but also start looking at that across the Sutton end as well. Yeah, lots of good work's been happening there.
Good, thank you. Any other comments, questions for Matt? Okay, next item, the noting Matt's report. Next item, integrated finance report. Lizzie.
Thank you. So both trusts remain on plan at month 2. However, you can see in the reports on page 219 and 220 that both trusts have used more non-recurrent actions to manage the position than in plan. So the plan included around 25% non-recurrent SIPs or efficiency opportunities, and we've used closer to 45%, and that's how we've managed to be on plan at month 2. Because of that position at month 2, that does put risk on the forecast position, but at this stage the Group Executive remains committed to the work to deliver the financial plan as agreed. Thank you.
Okay, Lizzie, thank you. Any comments, questions? I promise you we're going to be spending quite a bit more time on these issues pretty quickly as the year progresses, because we've got very significant financial challenges. Okay, very good, thank you. The IQPR, Integrated Quality and Performance Report. Michael.
Yeah, thank you very much. In the normal way, I will hand to Kate first on an update for St George's, give it more contemporary flavour, and then we'll follow with Epsom St Helier for Alex. I suggest in that we update on the UEC recovery plan, which is agendaed for approval as well. I think we can do that in one go, which will help us. Just by a couple of other bits, you'll note in the paper that we have received our Q4 National Oversight Framework results. There was some good performance recognised in our rankings nationally. So we are ranked against 132 other trusts, and they segment our performance 1 to 4. 1 is really good in this context and 4 is bad. I always have to explain that because sometimes it's the other way around. Both trusts actually for the final quarter of the year performed to a level 2, but there is an override because of the financial position, which means that we are a default 3. But actually underlying improvement, really, really good, and some good performance ranking changes. I don't spend too long on that because it's historical, but it's good. I think it's helpful for the public board to note some good progress when we have seen it. There's also an update in there around this year's oversight framework arrangements, and they are learning from last year and changing a few things. Notwithstanding the promise to reduce the amount of oversight KPIs, they've increased the number that they're using from 20 to 32. There are some, I think, quite helpful additions that we'll see come through in the KPI. Staff experience gets more exposure, as does, quite understandably and rightly, maternity and neonatology. So we will come back to that with the quarter 1's performance in a few months' time. Okay, let's start with George's. Thank you.
Thanks, Michael. I'll be brief and happy to take any questions. Thank you, Mark, for your comments about ED and 4-hour performance, which remains strong at St George's. Our 12-hour performance is fairly stable and declining, which is good. We are now all measured on corridor care nationally, and we track probably better quartile, but still, improvements that can be made. It's measured from the point of view of people on the corridor for 45 minutes or longer, and we track around a median of 18 per day. So we want to improve. That's not where we want to be, and we're really focused on reducing to 0 corridor care, linked to our non-elective improvements that we're focused on. Cancer performance, we just fell short of the faster diagnosis standard in the month in the report. However, we have brought that back into compliance, and we are in an improving position. It's really important that people get a fast diagnosis and they know what they're dealing with. We do fall short of the 62-day standard, and that is quite a challenge for us, particularly around lung and thoracics. We are having plentiful discussions about that. Internally, we've done a lot of work on the pathway, so the pathway is clean and things are happening at the right time, but the issue is theatre capacity and access to theatres, and thoracic consultant capacity, but there's no point bringing more consultant thoracic surgeons without the theatre capacity. So it does link a bit to our surgical strategy work that we're hearing about later in the meeting. That's going to be key to be able to free up the capacity we need at St George's for those more complex work that can only happen at St George's in South West London. And then our referral to treatment, 18 weeks, again, an improving position. We started the year in a much stronger position. Less than 1% of patients are over 52 weeks, which is a big improvement. And we are improving the number of patients seen within 18 weeks. This is a real focus of attention this year. We don't have additional money to fund additional lists, so this is very much about driving productivity improvements to deliver more lists and more capacity. I have to say our theatre utilisation is now at 85% uncapped, which is a significant improvement over the last few years, and they're maintaining that position. So there's not an enormous amount of productivity opportunity there, but hence the surgical strategy is going to be very important for us. The area where we're a bit more challenged at the moment is diagnostic weights. We've traditionally been really strong on diagnostic weights. That's largely driven by non-obstetric ultrasound. We have a significant issue around recruiting and retaining sonographers. There are other parts of our other sites in our system, not within our group, that are paying recruitment and retention. In fact, I think there's only about 3 trusts in London who are not paying a recruitment and retention bonus, which has left us quite challenged. We've got very interesting work to do at St George's, but we just need to look at pay rates, and it's not the position we want to get into in terms of inflation of pay rates, but they are very hard to recruit. Profession has been for many years, so that's an area we need to look at how we shore that up going forward. But I'll leave it at that, and if that's okay.
Yeah, thanks, Kate. Alex.
Sorry, I'm just having a sip of water at the same time. So I'll be a bit quick on the IQPR, and then I'll pick up the UEC parts. So the first bit I'd flag cancer performance across all the key 3 national metrics. We've achieved all the cancer standards again. I think that's the 3rd month in a row. So that's something I know I've flagged before, but something we're really proud of at Epsom St Helier through last year, and particularly after the EPR implementation. We had some real problems across some of the tumour sites, particularly gynae, particularly dermatology. But the teams have worked really, really hard to get us back into that position. So we're hoping as well to just do a bit of a good news press about that too. Another trust not far from us hit the cancer performance across one specialty and have put it in BBC News. So that's the kind of level of achievement I think the teams have done on that one. We've also made some really good progress on theatre utilisation. Again, we really struggled through last year, but we're now consistently over 80%, which, given all the new workflows and challenges the teams worked through, I think is really positive too. RTT and 52-week performance, we're doing well, ahead of plan. Recently, the regional and national team have changed focus from RTT performance to 52 weeks to our total PTL size, which is a bit of a surprise. But we're not quite on plan for that, largely because of the data quality issues and the innovation release, which was the upgrade to Cerner that happened in December time last year. But the team have worked up a plan, and we should slowly get back onto our operating plan for December time. But there was just a bit of switch of focus there. And then UEC, which is clearly our kind of main area of concern against the constitutional standards. So within the papers, you have this UEC recovery plan. Through last year, and again, not to say EPR too many times in one update, but off the back of the EPR implementation in May, our ED performance dipped significantly. Combination of two factors: one, data quality, and two, some of the workflow changes were really, really cumbersome for the teams. So the workflow that went from the emergency department into same-day emergency care was really cumbersome, and it led to a real drop in performance. Off the back of that, we went into tiering with the regional team, and we've done a lot of work over the last 6 to 9 months on recovery. We had sustained recovery through last year, got up in March to the 75s. But then we've taken a decision from the 22nd of April to implement what Matt alluded to earlier in the meeting, the UTC First model, which involved implementing UTC First model, but also eliminating what we call EDS-DEC, which was a same-day emergency care area we had for ED patients, which other trusts do still have nationally, but that we didn't feel was actually the right thing, and it wasn't the right thing for patient flow. And there's also been a bit of data quality and breach validation work that we've needed to do on workflows. So the changes we put in place on the 22nd of April got rid of EDS-DEC, brought in what's called EMAC, Extended Emergency Medicine Ambulatory Care Model. As I said, they're clinically supported models. We're really clear they're the right things to do, but the impact that they had was immediately dropping the 4-hour clock and the 4-hour performance, and that's because a significant portion of patients that used to be in ED-SDEC off the clock were now on the clock and being managed to 4 hours. So the plan you've got in the pack, there's quite a few actions in there, but it's broadly looking at kind of five key main areas. So really trying to strengthen our senior clinical and operational support at the front door and live timing against the 4-hour pathways. Streaming and utilising our SDEC pathways as much as possible. And actually one of the benefits we've had from the changes that we've made, we used to routinely bed SDEC. So at St Helier we'd have 12 to 14 patients who needed to be admitted to a ward bed every day sitting in SDEC, and as a result we couldn't actually use SDEC for its purpose to do same day emergency care and turn patients around at the front door. Through the changes that we've made, we've stopped that pretty much at Epsom. We've completely stopped SDEC bedding. At St Helier, we might have 1 or 2 patients each day in there. So the change has been really transformational, but really improving and streamlining those pathways, increasing the specialty responsiveness, so specialties coming down to our emergency department and providing specialty input quickly, and then a work stream around data quality and real-time management of patients as well. So those are the actions that you've got in the plan. The work we've done shows, and there's a trajectory in there that first gets us to a trajectory of 70%, which we're aiming for the start of July, and then slowly gets us up towards 78%, which is our operating plan. Within the plan, we've deliberately prioritised the actions, one, that need to be delivered rapidly, but 2, that don't come with cost attached. So really tried to focus on those actions first. But there are also actions within there and a need for some targeted investment. We've just going back around the loop with our clinical teams and our SLT teams to really scrutinise that and really make it as cost effective as possible. before we bring it through the appropriate governance route for GEC. But there will be a need for some funding linked to the money that we put in the business plan. So £2 million was initially allocated as part of the business planning process to support UEC performance. Although we also recognise that the financial position is challenged, and that's predicated on meeting SIP targets, etc. as well. So we're really trying to scrutinise that at the moment. There's details in the pack about the accountability framework. It's effectively coming through to SLT every week for an update, and I'm the exec sponsor for it as well. So the only other part I was gonna pull out was just flagging some of the changes to the UTC first model. And again, Matt mentioned some of them, but we made that change really with a view about improving some of the key safety and quality metrics within our emergency departments, and with support of the GERF UEC team as well. And we have started to see those improvements. So corridor care numbers have reduced, the overall time in the department has reduced, the bedding of SDEC that I just mentioned has dramatically improved. And where we've now got patients who didn't used to be on a 4-hour clock, they are on a 4-hour clock, we are turning much more patients around within 4 hours, which is a real quality improvement as well. So we're really clear it's the right thing to do. We're also clear that we know that we need to improve the UEC performance, and that's a key metric for us. And hopefully this plan outlines how we're planning to do that. Pause there.
Very good, Alex. Thank you. Questions for Michael, Kate, Alex? Phil?
Thank you. Well, just one on sickness absence rate, which I seem to remember a few months ago. I was pleased to see it was trending down in all 4 areas. It's just blipped up in all 4 areas. Is there any sort of is it a blip, or has the good work come to an end?
Is this at both trusts? Or?
It's both trusts and also Sutton Healthcare and Surrey Downs.
Okay.
It's blipped up in all 4.
Vic, do you want to speak to that?
Yeah, I'm happy to, Phil. It's not because we've particularly changed anything. So we do find our absence patterns are highly cyclical through the year, and the kind of March, April, May point is the lowest in the annual cycle, and then we see it rising through the summer, autumn, and winter to peak, and then it comes down again. So I think this is part of the natural trend. It is a big focus for us, and we are deep diving into the sickness absence management program in People Committee shortly. Not next time, but the time after that, to really unpack what we're doing around sickness absence. We've also had a recent internal audit report, an internal audit that we're waiting for the report of. So we've got quite a bit of insight coming through. But this is a difficult thing for us. There are national targets around our sickness absence levels, and we have a really large piece of work that we are in the process of standing up to really reach in and tackle this in a much more proactive way.
Thank you.
Okay, so we're coming back to that. Good question. Thank you. Yin.
Yeah, just to seek clarification about what you said about the UTC first model. So that was established in April, and am I right in understanding that by July you expect everything to, well, that there should be an improving picture?
Yeah, so start of July we said we'd be back up to the 70% performance. We dipped down to 61%, and sometimes we're in the 50s. Last month, it's not in the IQPI yet, but we've risen up to 65%, and then the last couple of weeks we're at 70. So that's aligned with that trajectory that's in there. And then over the next couple of months, we would get up to 78% performance. It's worth saying that for Epsom St Helier, we haven't been at 78% performance over the last few years. And actually, with all the new patients that are on the clock now that weren't before, that would be a really transformational position to be in for our emergency departments. But yeah, at the moment we're on trajectory, and we're just starting to post performance into the 70s now.
That's good.
Thank you.
Can you just say a word on how the surgical robot is bedding down at Epsom? Is the robot happy?
Everyone's delighted with it, yeah. I think we're still having some. I think people would like a bit more robot capacity, so I think we're still having some fairly heated debates about giving people the capacity they want. We've still got some, to Kate's point around some of their cancer challenges, we've still got some more discussions to have about how we can support some of the work from George's coming down to free up some of their capacity for some of the cancer cases as well. But yeah, it's been really, really well received, and I think colleagues are happy, particularly ones that are getting to use it.
Right. Okay. Thank you. So I think we can note, well, firstly, we can approve the urgent and emergency care recovery plan for ESTH. Thank you, Alex, very much for that. But I think, and then we can note the other parts of the discussion in the pages on the IQPR. So the next item, Michelle, I'm going to ask you if you could come close to a microphone, because the next item is maternity services report. There are two reports actually. Michelle, thank you very much for both of the documents. I'm going to ask you to introduce them and then ask Teresa and Nicola whether there are things they'd like to pull out in respect of each trust. Michelle, over to you.
Sorry. So there are two reports. The one report is the perinatal quality oversight model for Q4, and there's a report for each of the sites which would have been discussed at site level, but also in detail at the quality committee. And the second report is around the recent publication of the EMOS and Ockerman inquiries. Starting with the perinatal quality oversight tool, I'll probably take that report as read, given that there was a detailed conversation at a quality committee, and pull out just the more recent issue, which is around the escalation from MNSI. So about 2 weeks ago, we had an escalation at St. George's from MNSI, which was a thematic escalation around CTG dating back to 2019. So essentially, MNSI is the independent body that reviews all of our investigations. They had a look back to 2019 and focus really between 2024 to 2026. Within that time, there were 100 recommendations made in total, and of that, there were 15 recommendations linked to fetal monitoring, which we know is one of the sort of criteria for escalation to MNSI. So the ask was that we would review the effectiveness of our recommendations. We were given 5 days to do that. So we, obviously being new to the organization, had a fresh eye approach as well to all of the recommendations that had been made in that period of time. And we challenged ourselves to see, is there anything else that we could be doing now that would make a difference? Within the 5-day turnaround time as well, we took the opportunity to have an independent review of the work that we had done. So we liaised with the regional obstetrician and as well as the Matneoist obstetric team who are linked to St. George's. We've now responded to MNSI within the time frame that we were given, and in terms of a process, they will be taking our response to their independent panel and reporting back to us. So I have added that to the maternity board, which is on the 27th, because by that time we would have heard back from MNSI with a view to then sharing the detail, perhaps at the next committee. So I'm happy to take any questions on that before I go on to the next matter, if that's okay.
Great, Michelle. Thank you, Andrew.
Yeah, the CTG monitoring and interpretation was obviously something that came out of the previous CQC inspection. What we had at quality committee was just the verbal notification of this. What I'm not clear about is where we think we're at now. I assume that will come to the July maternity board and
Correct.
we can go through that in some detail.
In detail, yeah. So we're bringing the escalation and the response to the maternity board on the 27th of July. But in summary, the recommendation was less about interpretation of CTG, but more around decision making. So similar to the conversation we were having earlier on around individual decision making. So from an assurance perspective, we have implemented quite similar to Martha's rule, like a call for concern. So if there is a discordant view between an obstetrician and a midwife, for example, that there is a call for a second opinion, and that has been implemented. We've also implemented a CTG huddle, which bears in mind all of the human factors around distraction and fixation and all of those things, so that we can have oversight to support that. But we will bring the full report to the 27th.
Thanks, Michelle. Any more on that? Teresa, Nicola, do you want to add anything?
I don't think particularly. I think Michelle's covered everything from my perspective for ESTH.
Yeah, I agree. Thank you very much, Michelle.
Thank you. So going on then to the second report, which is the summary paper on Amos and Ockerman. As you know, these reports were both published within a week of each other. Very hard reading. The Amos report is a systemic review of 12 maternity services across the country. The Ockerman report looked specifically at Nottingham, 2,500 cases, and very sadly found 500 cases where there was avoidable death. And so there is a lot of alignment in the recommendation between those two reports and also alignment with previous inquiries. So in terms of what does that mean for gesh? Looking at those recommendations, I think the board could be assured, looking back to the improvement programs that we now have in place at St George's and also at Epsom and St Helier, that they absolutely mirror the key themes that are coming out of those recommendations. So I've included in the report just the digital synthesis of the day we had at St George's, and you would see in there culture, leadership, governance, clinical pathways such as triage, equity, listening to women and families, IT, STs. Those are all things that we've been focusing on together with maternity oversight, and they're now in those national reports. So similarly, those are new pieces of work that now need to be embedded, certainly at St George's, at Epsom and St Helier, probably at a slightly different place. But across the group, we are looking with fresh eyes again as to what else we can do in relation to those actions, recognizing the volume of work and the number of recommendations that are coming through. NHS England have also provided us with a 10-point sprint a plan that came to chief execs, I believe, and we need to be compliant with those 10 points within the next 100 days. So there are, again, some new recommendations within those. So there is the need for the mortuary audits to be completed by the 31st of July, and each of the site leads are dealing with that. And that is going to come to the maternity board on the 27th as well. And there is also the need to roll out Martha's rule within maternity at gesh, which is new for gesh, not new to every maternity service, but we need to take a stare from the national team. There's also a need to do some benchmarking against things that we've already been working on, such as triage and the home birth service, which we have in hand. So in terms of next steps for us, we will continue to prioritize those 10 points. Also on the expert reference group, we met on Tuesday, and that informs the task force that's led by the Secretary of State. So there'll be more coming from the national team as well. That work has started as well. And we will feedback. Obviously, we now need to get some time to do detailed benchmarking against both of these reports, and we'll have that on the maternity board as well. So it'll be a very busy maternity board on the 27th of July.
Okay, very good. Comments, questions to Michelle, Natalie?
Yeah, thank you. I mean, I've read both of the reports and I've read some of the previous reports, and as you said, that a lot of the findings are sadly very, very familiar. And thank you for all of the work that you're doing to help us strengthen board oversight in this area. It's clearly really, really important. Given that how closely together Ockenden and Amos were, and that maternity is a difficult space, I wanted to ask for your sense of how our maternity workforce is feeling, because it's not easy having these reports very public. So how are our staff feeling?
Yeah, it's not easy having these reports, and then if you overlay that with leading fragile maternity services, all of the discussions we've had, it just gives a view of what that landscape looks like. So we have been really supporting the maternity teams, writing to them individually, given opportunities for debriefs and so on, because and again, having the experience of working at an organization where there was a negative inquiry, it supports us in leading the teams in that regard, not just the maternity workforce but also women and families who are accessing care now. So one of the first things we did with the publication of this report was to send out some communication to all of the women who are having care at either Epsom and St Helier or St George's. So if you're worried, if you're concerned, please do contact us. But we continue to meet regularly with the team just to also give them some hope, because within those reports, as negative as they are, there is acknowledgement of areas like East Kent where improvement had been made, as well as Nottingham where these things have happened, but there was improvement as well. So just helping people to focus on the positives as well, because there is a tendency to just focus on lots of things that have gone wrong. But within, we know that for everything that goes wrong, there's probably 10 situations that have gone really well, and we can learn from the positives as well. So it's trying to build that positivity.
Thank you, Pankaj.
Oh, thank you, Michelle. I mean, a lot of the themes that come through on these reports is around culture and team dynamics, and we had similar reports from the CQC. How do you actually measure the culture, because it's an intangible thing, and how do you then turn around and know what you need to do differently within the team dynamics, whilst at the same time we're doing a lot of things to improve culture at the broader level? So I'm quite interested in that.
So I think firstly it's about understanding the culture before you can start to measure it. And when you're new to an organization, you actually see it and you feel it. I think there are informal ways of measuring the culture. So you hear it by going into the clinical areas and you see what you hear what people are saying and what their focus is and how they're feeling. So there is that. And then there are more formal ways of measuring that. So whether that is looking at your national surveys, looking at your complaints, how many women are saying that they were treated with dignity and respect, impact, what is coming through staff. And I think what's clear in these reports is about us not just looking at data, but understanding the qualitative approaches as well. So what are women seeing? What are our staff seeing? And then using that to triangulate. And that's how you can really appreciate that shift in the culture. And that's my experience. I mean, we are focusing on culture and improvement, particularly at the St George's site. Each of the sites now have a culture improvement plan. Epsom and St Helier had already started theirs. St George's had paused theirs in 2024, so we've relaunched that, and I'm certainly working with Richard to look at interventions that would help. We've procured some civility saves lives training. We've procured cultural competency. We know that training isn't the be all and end all, but sometimes it's a good starting point. So.
Thank you. Richard.
Yeah, a lot of the emphasis of Ockenden and Amos, I think quite rightly, is about the culture of how we treat mothers and patients and women. But as Michelle has been referring to, it's really important how we treat each other. And I think in terms of Pankaj's question about how we measure culture, we can get feedback from many different sources, and we can learn about the way that it feels to be a member of staff from our staff survey, but also from feedback from outside. And I think we do have work to do to make sure that we've got a really healthy team culture based, and Matt was talking about the way that teams work and how you can only give safe care where you have good team working and civility. I think that we've got some work to do there, and we're very committed to doing that.
Yeah.
Thank you. Leonie.
Michelle, thank you for this, and obviously the reassurance that we're getting onto this quickly, and we'll see it at maternity board. I just really wanted your comment and reflection on the resource implications for your senior midwifery team, because it does sometimes feel like we think of maternity senior midwives like pack horses, and we just keep loading more and more things on. And it's certainly what these two reports have done, without any acknowledgement of how much work it is. And it was just really to understand from you how
Absolutely.
the team were coping with that.
Yeah, and there is a lot, and I think it's about us having to have that realism about prioritizing, and certainly that's what we're trying to do. But then at a national level, that's what everybody's seeing as well, because when we look at pockets of excellence across the country and you drill down into it, it's because if you look at listening to women and families, for example, where that works well, there's a well-resourced team behind that, and it's about how we can champion that at a national level, because certainly there is a lot to be done, and some of these recommendations will require that resourcing.
Thank you, Andrew.
Yeah, and I mean, Michelle, I just think your leadership coming into this has been excellent. And we're talking about the midwifery leadership resource required to do it, but clearly part of the answer is joint leadership between midwifery and medical leadership. And are we clear, I guess particularly Richard, are we going to get the right medical leadership support for making this happen? Because it really needs to be a joint approach, not just something that's led by our chief midwifery officer.
Yeah, absolutely. There's no choice. We have to have medical leadership, and some of that leadership will need to come from me and from the site chief medical officers and from the divisional chairs. But absolutely, this is about doctors as well as midwives. And the culture of how we talk to each other and look after each other is absolutely essential in both professions.
And just to add to that, Andrew, there's a recommendation within the 10-point plan around that. So it's around the leadership from a medical perspective as well as maternity.
Okay. Thanks again, Michelle. So we note that report as well, and with the commentary we've just had. I'm now going to award you a 15-minute breather, which means that if you, it's going to be 17 minutes actually. So if we can return at 2:45, that would be great. 2:45. Okay, folks, this is your 1-minute warning. 1-minute warning. Right, everybody, we're approaching 2:45. Andrew, the next item for you and Leonie is the Quality Committee's report. I think we're all back basically, so if you're ready, the two of you, to introduce the Quality Committee's report, over to you.
Yeah, I'm going to introduce it. I'll take the report as read, three things we pulled out in the executive summary. The quality accounts, which we approved, maternity services and interstitial lung disease we've already dealt with in this meeting today. So there were just two other things I wanted to pull out from the report as a whole. The first was about never events that we're continuing to monitor every quality committee meeting. And we're still concerned that there are never events occurring around two key themes, which are again detailed in the report. I guess the main thing to say is, in terms of action, we've agreed that we need to have an external theatre review at Epsom St Helier. That myself, Leonie, and Richard, the Chief Medical Officer, and the Chief Nurse need to agree what sort of oversight we think we need to have of never events and what would give us greater assurance. So what we need to see to give us the level of assurance we need to be confident that we're doing everything we can to prevent never events recurring. We're confident that we're learning well from never events, but we seem to keep getting them. So we just want more assurance around that. And we're going to continue to look at those at every quality committee. The final thing to pull out is around the board assurance framework. So there was two strategic risks that came through quality committee. The first one we agreed with the risk score. The second one, which was strategic risk 8, which is about maintaining and improving quality and safety of care during the tricky period that we are in terms of financial pressures and transformation. There was a proposal that the likelihood score should go down from 4 to 3, and we didn't think we were ready to do that. What we did say, though, was that there were some things that would give us more assurance, that would help us consider moving the likelihood score down from 4 to 3, and that was when we've seen the quality governance improvement work come to fruition and start to get greater assurance around the quality governance improvement plan being implemented, when we can see that the fundamentals of care are starting to improve. So we haven't been delivering what we wanted to in terms of achievement of fundamentals of care metrics. When we start to see that, and when we start to see some of the cultural improvement programme work mature, and we feel then we'll probably be in a position to reduce the likelihood score down. Realistically, that will probably be around, we're hoping to do that in around about March next year. So that's the target we set ourselves.
Okay, thanks. And overall, you're proposing a reasonable assurance level is what the document tells us.
Reasonable assurance on?
That's a good question. How would you describe this, Steve? The reasonable assurance on the report, I suppose, on the issues covered in the report.
So the Quality Committee tends not to provide an overall assurance rating for the whole of its meetings. It tends to do it by individual items.
What you have got in here, I think, is a description of the assurance level that we've got for individual areas. So I guess we're proposing for the individual areas different assurance levels. So for the maternity services, we took reasonable assurance, and for never events, we felt assurance was limited for the reasons I've outlined.
Okay, fine. I think there may be an error in the report on page 384 of diligent. Can we have a look? Let's just have a look at that. Since it's
on the cover sheet, yes.
The cover sheet.
Yeah. I think that's I think that's probably not pointing you in the right direction.
Okay, fine. Any comments, questions for Quality Committee? Okay. Finance and Performance Committee, Bidesh?
Thank you, Mark. So I'll take the paper as read, but add, I guess, one additional overlay in particular, which is that NHSC has placed gesh in what they're calling formal enhanced financial oversight, and that reflects concerns about the group's financial trajectory. And Lizzie sort of alluded to a number of things around new pressures, the underlying run rate, and the speed of progress around both the BAU and transformation SIPs. So, how does the enhanced financial oversight manifest itself? And I'd say sort of two different things. One is they will continue to attend the Finance and Performance Committee, and we welcome that. And they'll also attend some other gesh governance meetings. But it is worth emphasising that this is sort of first stage oversight. And when I spoke to NHSE, they were very keen to point out this is really about help and support. And I think we should view it as exactly that, especially as we have some difficult challenges to work through as we try and navigate and getting ourselves back on the commitments to the deficit plan. A couple of other things that I'd mention on performance, amongst other things, the committee spent quite a bit of time discussing children's therapies in Sutton and also UEC at ESTH, as we were discussing earlier. Both will come back to the committee in autumn for a proper deep dive, so that I think is very timely. And then the last thing is that our two risks that we oversee are timely access to care and financial sustainability. We agreed that we wouldn't change the risks score, but what we did ask for is a bit more clarity on what's sometimes called the path to green. So what are the mitigations that take you from where you are today to what your target is, and then that helps the committee to monitor and track progress.
Okay. Thank you, Bidesh. Comments, questions on that? Can we just explicitly note also then that we're happy that the system of internal control is adequate and operating effectively, and indeed we have very clean set of accounts as we discussed recently, which is very positive, but we have quite limited assurance overall, basically because there are big questions about the deliverability of the current of the plan because of the deficit and the big challenge in getting to back on plan. I think it's important to be clear about that. Okay. Next, we've got the People Committee report, Ian.
Thanks, Mark. So I'll take the paper as read, and you will see in section 4 of the paper all the matters that the committee received assurance on. And most of the matters received either substantial or reasonable assurance, apart from one aspect of the resident doctor's 10-point plan. So I'd like to raise that, if I may. So in terms of the administrative and transactional items, for example, the provision of annual leave and the training, the committee received reasonable assurance. But so far as the first 10-point plan is concerned around well-being, the committee received limited assurance. So the committee heard from the peer representative from St. George's, who informed the committee that there were still quite a lot of things to be done. So, for example, doctors were still sitting on occasions on bins because there were not enough chairs, still using broken computers. They were lacking secure lockers, and actually sadly resulted in some thefts of their personal items. So happy to say that Matt was at the People Committee and has actually really got involved with this, and the peer representative has written to Matt, and I think the plan is to have a very urgent meeting to ensure that the quick wins and quick work can be done. There's going to be a steering group meeting on the 22nd of July to talk about estates. So it's something that the People Committee are very much on top of, and we were very grateful to hear from the peer representative from St. George's. As the board lead, and Richard being the medical lead, we also have bilaterals with the peer representative to make sure that there's a sort of ward-to-board oversight. So I'm happy with that. And then just to say the other two things that we wanted to escalate to the board, the e-block matter we've already discussed, so I don't need to go through that. But there was a reference in the paper about sort of interpersonal difficulties and mediation requirements. I'm going to invite Vicky to give a bit more context to this. Thank you, Vicky.
Yeah, thank you very much. As part of our handover from our site chief medical officer to our new site chief medical officer, CJ Francis, we took the opportunity to do a stock take of any and all kind of HR or people related issues that we have within our medical teams at St George's. That obviously is a good thing for us to do periodically. We know from the really unfortunate occurrence in the ILD service that actually paying attention to those relational issues is one of the early warning signs of a service that might be in trouble. And we absolutely know that our relationships and the outcomes for our patients are really closely tied together. So we took the opportunity as part of that handover process to do that. Now, this listed a whole variety of things, maybe where there's an issue with one particular doctor that we are kind of well known in dealing with, or where we just have concerns that the team might not be working as closely together as we'd like, and everything in between that. So this was raised because it's work that we're done, and it's something that we want to be really accountable to the people committee on, and that's the context for this. It's a part of a wider piece of work that we're doing, which looks at how do we resolve conflicts that we see within teams more quickly, more effectively, and we're doing things like formalising our mediation service and training up a lot more mediators. We're wanting to triage our grievances and give and offer some training to both our staff side and our managers about how to have really good conversations that seek to get to the heart of an issue before it escalates into a formal process that can then be harder to deal with. So yeah, that's the context, and I just wanted to provide a little bit more information because yeah, we just think this is a really important aspect of our culture that we want to improve.
Okay, thank you. All right, any comments, questions for people committee? And we've got a reasonable assurance overall here, because in the areas where there are weaknesses, we've got a credible game plan. That's the rationale. Okay, good. Next is infrastructure committee report. Phil and Claire.
Shall I?
I was going to say, why don't you take the first half and then I'll take the second half.
Okay, I'll
'cause
start on
it's neatly
estates.
split in the summary, as I'm sure you've all noticed.
I'll start on estates and then we'll go on to digital with Claire. So a couple of things to bring out on estates. The ITU project at St George's has been delayed and there are contractual issues there. However, the building remains scheduled to be open in the autumn, in this autumn 2026. So we'll get the use of the building, but there are some contractual issues to be worked through. Some good news at Epsom. We've received funding to put up basically a large amount of photovoltaic panels over the car park, which we bought recently from Legal and General. So that is be good news, and we'll be getting some free power of that for Epsom shortly. So that's all good news. Just mentioned the firework we're doing. There's been some good news again at Epsom where Surrey Fire and Rescue have visited. They're pleased with our progress, and we've only got a small amount of things left to do at Epsom. There is more to do at St Helier. We're making steady progress there, and London Fire Brigade are still working with us as we go through those improvements. Just mentioned the board assurance framework before I hand over to Claire, and it's strategic risk 5, which is about the estate's modernisation infrastructure, and it's got a risk score of 20, and the aim is to mitigate it back to I think it's 16. And we had a long conversation about whether this is really possible with the condition of our estate. And I think we agreed as a committee that it wasn't possible. Whatever we do and however much improvement we make, the small things we're doing, we're going to really struggle to say that actually in 2028 we've mitigated the risk down from a 20 to a 16. So it's an important point to note, because generally risks are set up so you can do something and mitigate it and you feel you've succeeded, but I think we're going to be chasing our tail, particularly at St Helier, and I think it's just worth raising that. I'll hand over to Claire to talk about digital.
Almost seamless, so I can get my microphone on. Yes, so I think the main thing I would draw to the committee's attention, and I don't want to steal Michael's thunder for later, is our digital strategy, because I know we're going to come on to it later, which and I think one thing I do need to call out, and I would like to call out for the record, is that we have a new chief digital officer, chief information officer, the acronym is complex. GDCIO.
They're both right.
CDIO.
Chief Digital Information.
Chief Digital Information. They were too many letters. And Mark has already driven quite a lot of significant change, and kind of has created this strategy, aligning it very neatly with the priorities, with also the aspects that we call out under board assurance, and with some other pieces underway under working closely obviously with Ralph and Michael. The other piece I would call out in terms of the digital priorities and strategy is that we've looked to integrate that with the available budget. So there has been some capital that's allocated and released for that, and so we're looking at that within that, and then that will also link through to things like the board assurance framework, where over time some of those aspects where we have some key dependencies or key risks that we're focused on will also be able to be mitigated through that. The other pieces I should just call out, although Stephen might be, is that there's our annual report to the board for people to read, and then we've also updated our infrastructure committee terms of reference, though that is relatively minor in terms of basically it's making sure that Michael and Ralph and Mark can come to it, because that wasn't the case before, and obviously we need them there.
Great. Thank you both very much. Comments, questions? I'm not sure if this was deliberate constructive ambiguity, Phil, in what you said on the ITU new build at St George's. But what is it? It will be operating in the autumn.
In the autumn, there'll be a new building there in the autumn ready for the operation, and I think it's going to work. The last I heard, it'd be fully open. There's one small area that might not be quite fully open, but otherwise it'll be ready in operation. I understand. Is that Matt? Do you understand that?
Yeah, I mean, I went around it last week. Sorry, apologies. I went around it last week. I'm meeting with the chief exec and chair of Vanguard in the next week or two. There is no current signed off agreed plan, which was due at the start of July. So there's more work to do on that, and when the building opens, it will take a number of months to fully commission and then occupy. So I think we'll probably talk about that more at Infrastructure Committee, but also potentially Finance and Performance Committee, depending on the outcomes of some discussions.
Okay, fine. All right. So thank you for the report. We're noting. I think it's important just to register Phil's point that some of the infrastructure risks we're carrying are not mitigatable within what's available to us to do, and that's just it's not a desirable situation, but it is the fact of the matter. We've received the committee's annual report, Claire, thank you, and I think we're all happy to approve the small changes to the terms of reference. Right. Oh yeah.
I just wanted to make a comment on that, and it links to the e-block discussion we had earlier on, just around at some point it would be good to, through Infrastructure Committee and onto the board, to reframe risk and what we think are acceptable risk. The danger is we have incremental risk rise because we know we're not keeping up with critical backlog maintenance. And over time, that's just slow and steady increase year on year. But we need to pay attention to that around what our risk appetite is for running services. So I think we just need to think about how we curate a conversation about recognising the total risk on site of all different things that could happen, bearing in mind we know what the issues are on that site. So maybe we can have a conversation out of here around that.
I think that would be really helpful. I think it would be helpful to understand better, probably, well, for the committee to understand better how the backlog maintenance calculation is done, because it's really about asset replacement, and I think they're slightly different things, and I think we could have a conversation about that, because most assets have got a life, and that means then this camera or whatever has probably got a 15-20 year life, and then but if you make it run for 25 years, that isn't the right thing to do. We should have a replacement of asset program. Well, I think we're running things beyond that already, and so I think there is a bit of understanding which will help us with that risk conversation, Matt.
Yeah.
Okay, good. I think that's really helpful actually, because I think we should just be a bit more transparent and clear about all this, as it's a sort of boiling frog thing.
Yeah, it is. Yeah.
Okay, good. Technical term there. Great. We're going to go on to the item 5 material. Michael, we're starting with you and the group strategy update.
Yeah, and we are way ahead of time. So I've got for the surgery one, Andrea Sott's joining us. I'm not quite sure whether she can arrive early. I have messaged her. Mark's on his way, so hopefully we can manage maybe manage the order of things as we go through. But for the first paper, it's just a routine 6-monthly update on strategy development. The board has now a quarterly strategy and transformation session. We had one just recently on the 1st of July. It's been 5 months since we refreshed our strategy and submitted it as part of the medium-term plan to NHS England. So it's relatively early days since then, as I think the report portrays. There are some pieces of work that have been running for quite some time before that. However, so there's a range of components, and we've outlined them here as from the local improvements and what we're doing at a very ward level down to the more top-down corporate enablers and the transformation schemes themselves. Today we've got our first clinical strategy. I think it's our first since we refreshed this, even agreed the strategy as a whole for surgery, which is great. I think that's a cause for minor celebration to see that work come forward, and Andrea will, as one of the clinical leads, walk us through that shortly. And we've got digital strategy in a moment as well, but still only on an enabling front. 4 out of 6 are in place as of the end of today's meeting. So there's still quite some way to go. There's a significant reliance on the transformation schemes towards our improvement in our care, but our financial sustainability as well. And it's important to acknowledge that. And for some of the assumptions that we made in our plan for this year, those transformation schemes are not meeting those expectations yet. At the moment, and they are going to really struggle in this year. Inevitably, you want to shoot for the stars, and that is really difficult with some of these schemes. The ones which are doing really well and progressing are more mature. So surgery, as I've said, we'll have today. The board has met the paediatrics teams twice on the paediatric strategy development, which is looking great. And I think last time we met with Tara to discuss clinical administration. That scheme's been running a year. So it demonstrates these things take a while, and shortcutting them is tough. Some of our schemes rely also on a lot of collaboration and success across the system with partners. Non-elective care, outpatients, long-term conditions are examples. So it is a different way of working, and we're also up against daily pressures. Capacity management when you've got corridors full of patients is very, very tough. And issues like we've discussed today around E-block are destabilizing when you're trying to drive change and bring people with you. We met as a board for our session on transformation. We had a really good discussion also with the leadership forum, as Matt mentioned earlier, the areas that we are prioritising to move the strategy forward in its delivery mode is particularly the discipline around the portfolio management. So there are some schemes we are not progressing now in order to alleviate the pressure and allow capacity for others. Capacity and capability in terms of the skills that we have in-house, and we are prioritising in-house talent versus capacity being bought from outside. We're always managing that tension, but we believe in internal talent delivering this change because it will be better and more sustainable as a result. But there is a trade-off about their physical, mental capacity to be able to deliver it and the day job. And lastly, and the inclusion board reflected this back to us when we met, is actually how do you bring more people with you with a compelling narrative? How do they feel the change and understand where we're going, and therefore pull in the direction with us too? And much more work to do on that. Matt continues to meet the SROs of the top 5 schemes, and 2 of those 5 are really ready now to turn their schemes into blue, and we've outlined in the portfolio update what those steps look like. Blue, for those who not as close to this means ready to sign off for financial saving and move into implementation mode. But we've still got really quite some way to go. I think on that note, I'll just conclude there, Chair, and happy to take questions.
Okay, Pankaj.
Thank you, Michael. I mean, there's lots going on. I mean, how can we make sure that everybody in the organisation understands what this means for them? Because the reality is we can get the best processes, systems, data, organisation, etc. But until people know what they're doing, and you said it quite clearly there, the capacity is not there. But I mean, one of the key lessons I've picked up is there's a huge cost to pay for engagement up front. And if you don't do that, you'll be just managing the cost of resentment that comes later on. How do we manage that balance between making progress, keeping the momentum, but at the same time making sure we're taking people with us?
Yeah, I think that's a great question. I think as you saw with Tara's scheme with clinical administration, they've run workshops with 750 staff affected by that change. And as we know, with engagement around the necessary works on e-block, that's not always a comfortable position to be in, but it's necessary so whilst you can't answer all the questions, people feel they're with you to an extent, and maybe not in control of the outcome, but part of the process to get there. So that's really important, but that takes time. That's not efficient, but it is better. So people need to feel part of it. The high performing wards work that we've mobilised, we want to be on 50 wards by the end of the year, where they are on a daily basis working on key improvements that they feel strongly about, which connect with the things that the board feels strongly about. So there are two examples of people feeling part of the change. But not everyone's going to feel this. And there's also, I think, more for us to do about how do we set out our stall and the story for the future, recognising neighbourhood care is a bit nebulous in parts, recognising, we don't have all the answers, but having a vision of that we want to shoot for and being able to paint a picture as to how people can come along with us, I think at a narrative level is not trite. I think it's actually very real, and I think we've still got a bit more to do on that.
We've had a couple for the last couple of months actually from the inclusion board. This is picking up Pankaj's point. This thing flagged about a gap between the level of understanding of what's going on and what we want to do at very senior levels and what people are hearing at the mid-level. I wonder if at some point, maybe with Amanda's help, we should have a discussion to understand what we're doing to address that. What do you think? Is that an unreasonable thing to do, or?
No, I think you're absolutely right. And some of it comes back to Matt's point about the leadership forum. There's more to do shoulder to shoulder, so that the experience and the leadership of the change is shared, not felt done to.
Right.
But yes, we should absolutely bring that back for a fuller discussion, because it's probably one of our primary risks. Anna is helping us with developing a narrative that can permeate more for the people that we don't reach personally. So we can absolutely bring that back. Perhaps the next strategy session we ought to put that as a spotlight.
And maybe also picking up what comms have learned about how we know what people know and what we know about where people get their information from.
Yeah.
Okay. The other thing just to note is you're constantly updating the SRO arrangements for a lot of these programs. Clinical support services, I detect from the paper in the middle of working out who the lucky new winner of that transformation program is. Right, but that's okay. I mean, people move on
yeah. So we've got a few SROs moving on. That carries its own risk.
Right.
I didn't add that to my list of woe, but that is another one that we've got to manage. CSS, clinical support services, is we have agreed that we will take forward the pharmacy strategy. We're going to park some of the other aspects to that. Just my point about there are some things we need to step back from.
Mm-hmm.
Because otherwise we are going to run the risk of just being way too shallow and not drive the change at a deep level. So that's one example where we've actually narrowed it to pharmacy, and we'll come back when capacity is better. We'll come back to the wider aspects of CSS.
Okay, fine. Good. So there's a few things to follow up on that. Thank you, Michael. That was very helpful. Oh, sorry, Bidesh. Beg your pardon.
Thanks, Mark. I suppose one question and linking it back to medium-term plan and expectations with NHSE, and I mean this is all good stuff. You know, it's starting to take shape, but what's the mechanism for you know, I guess regularly updating our trajectory and then making some judgments around the risk, because you know, those are the things we're going to have to kind of talk to, you know, wider stakeholders about, and and it's all about, you know, ultimately what's deliverable in what kind of time frame.
Well, actually, we'd probably do that every month as part of the financial reporting, as we've seen in earlier papers around different scenarios about where we might end the year, and that's refreshed against. In each month, we meet each of the top 5 schemes to refresh actually where they're getting to and where they're likely to get to, and we have to moderate our expectations against to what. In some cases, that's contextual about what's happening outside. In some cases, it's how much we're delivering inside. And inevitably, with enhanced oversight, NHS England will be much more beside us for those discussions too.
And I guess that mechanism I'm, you know, obviously familiar with, given the committee I chair, but I think that you know, we get surprised a little when we're a little further behind than we anticipate, and it's I'm sort of pushing you to think about how we get ahead of it a bit. You may not have an answer right now, but
I think there's a real natural tension between moving these as fast as we can, but slowly enough to keep people with us. Some of these are big changes, and going back to our inclusion colleagues' comments, inclusion board colleagues' comments, how do you keep the organisation with you around some of these quite significant changes and delivering the timescale we've been delivering? And I think that's the debate we have a lot. We have quite a deep dive every month across the 5 schemes that we're really focusing on and have the potential to deliver quite significant savings collectively. But it's about maintaining connectivity, credibility, but delivering with people on board rather than leaving people behind and doing it regardless and then dealing with the consequence of that. And it's, in an ideal world, we wouldn't be doing some of these things as quickly as we're having to do. It's a reflection of the financial position that we're in. So it's that sort of trying to balance that all of the time. And I think we have really reasonable discussions that Matt and Michael lead with us on a monthly basis, where we push this around a bit. And, you know, as an SRO, I feel personally supported by those discussions, but it is tough.
I think it is a good way of putting it, Kate. I think that Matt.
Yeah, I think it's maybe a practical example of that. Well, the first thing is if things aren't working, we should kill them quick. So if we're going to run into issues around a renal building, which we talked about earlier, then the renal transformation program changes its timeline and changes the emphasis. So I think there's something about dialing up and dialing down things. But you know, the hot topic is how do you manage corridor care, left shift, and closed bed base down? And what's the order, and how do you give people confidence that you can improve corridor care and experience for patients at the same time as you're going to have to reduce bed base, because that's where cost is, and that's the system expectation of us. And that requires a leap of faith. A leap of faith from our ED colleagues that actually the patients aren't going to be left in ED and they are going to be treated well on a ward where they need it. And it requires our ward colleagues to be confident that they can discharge patients and we can treat them in a different way. And so the whole conversation with Kate has been, well, okay, there's some money within the local authorities which we've put in. How do we leverage that? And new methods of how we actually get people out of A&E quicker and then discharged via other mechanisms. We've got something that the Law Free have done, which is quite interesting about population management and health. And then you've got the option of rehab beds around, do we change the dynamic and open more rehab beds but close more acute beds? And in the combination of those 4 things to achieve that one thing, it hopefully gives people the confidence that we know why this can work and we're happy to go along with it. And also we tread a very fine balance between everybody feeling that we are bureaucrats and only really care about money. And actually what we really care about is treating patients much better and in the right place. But when you're making these changes, people are really concerned about safety. So it's how we get that right balance of that, knowing that we've got a solution which will help, with some guardrails of if it doesn't work, what do we do and how do we reverse out of it? And that's the real thing we're struggling with in terms of balancing the balance of speed and financial delivery
with as cases, taking people with us.
Okay, good. That's a helpful discussion. Thank you very much. And we thank you, Mike, for the update. We note that.
Mark, sorry.
So then, oh, Claire, sorry, go
That's
ahead.
okay. I think we touched on this earlier, but I think the point I would want to make sure we reiterate is communication clearly is key, and how we cascade this through the organisation, not just in terms of what strategic goals we want, but what cultural goals we want, and then to some of the points that I think we've been talking about in the round, is how do we get people to see the financial challenges as part of, their ownership, and how do we get people to view this as their, they own all of this as well. It's not just sort of, it's not just centralized. We want people to feel that level of ownership, and I think that will also speak to some of those cultural aspects. So I'm really looking forward to seeing that communication plan, and how we're going to address that. But I think that's a point we really need to draw out and make sure we have at the heart of what we do.
Okay, I think we got that. Thank you, Claire. Very good. Good. So we're going to come on to the group surgery strategy. Welcome, Andrea. Lovely to have you with us. Could we ask you, could we find a microphone for you to speak to?
Can I kick it off, Mark?
Yeah, second. You're going to start it. Yeah, that's great. So you're very welcome. Thank you to you and your colleagues for all the work on this. Looking forward to the discussion. Michael, you're going to say a couple of things to kick us off.
Thank you, Andrea, for racing across London. Take a breath. Aircon's not bad, but it's not great, so relax. So thank you. And just to link it to Claire's final point there and question, we will talk some more about communications, but by God, it doesn't work if it feels done to, or, this is what corporate stuff's going on, please be engaged. That doesn't work in the NHS. And this is a strategy which is a really great example of people being part of the change. And I'm really grateful for Andrea joining us, as orthopaedic consultant and trauma surgeon, and also chair of our clinical standards and strategy group for surgery. Shami and Tara, I think, are both on holiday this week, and Andrew's very kindly agreed to join us for a few minutes just to give us a few headlines and to take questions about how this strategy has developed. It's a great example as well of not just clinicians working across the group, but the group showing value of being a group and beginning to shape what locations our hospitals are going to be really strong at and going to be strong at in the future. So it's not just about surgery. I think this is a really lovely strategy to start with, because it amplifies the benefits of a group being a group. So I'm very grateful for Andrea's time, and I'll hand it over to you.
Thank you very much. Can you hear me?
Yes.
Good. So I'm Andrea Sott. I'm an orthopedic surgeon. And 29 years ago, I worked in this hospital doing carpal tunnels in a very old building with a local surgeon. I trained at George's. I started at Epsom in St Helier as a consultant, and I know some of you through my work as a division medical director, surgeon, and Sveliog director. So I chair the CSSG, and I'm really grateful to Andrew Parker and Julie Alexander from the strategy team, and Ralph, as well as Tara and Shami, who can't be here today. So you have seen the papers and the slides, and I'm just going to go very quickly, briefly over it so that we have a little bit of time for questions and answers. Oh, there it goes. Already not going. So why do we have this group surgery strategy? Because currently we're facing challenges. We have long waits. We have differences between our sites. We're operating on 4 sites, if you count Sveliog separate. So we have St George's Hospital, we have Epsom and St Helier Hospital, and we have Sveliog. And so we have 4 different sites, taking out Roehampton, where we had to change our strategy last minute, at the beginning of this year. We actually thought it would be best if we could rethink how the patients could get treated better, quicker, at the right time, by better expertise, shorter waiting times, daycare surgery facilities, and really re-identifying the characteristics that we are each very strong for. So George's is very strong for tertiary surgery, cardiac, bariatric, neuro, pediatrics, etc. You know that it's a super tertiary center. and we are very grateful. I trained there. I'm very proud to have trained there. Epsom is really strong on elective surgery. We know from Svelio that this works. So patients will travel, and they have been traveling for the last 22 years to get excellent joint replacement and other surgery. So I do foot and ankle surgery at the at Epsom, at the Elective Orthopedic Center. And we have never had a patient complaining, oh, do I have to travel to? We haven't, because they're in and out in a day, and our day surgery rate for hip replacement is now 1.2 days. So that's the stay. And for knees, it's 1.4. So we have an example what can be done. And we have this idea, or we had this idea a long time ago, even when Daniel was still here. We had this idea of seeing how we could work together better by having hubs that are nationally mandated now by NHS England, and identifying best sites for specialist care for our surgical patients. So you have seen everything on the slides, but really I just summarize it. So how we see it is, and what we are working towards is that we identify Epsom Hospital as an elective surgery hub. We already have a hub there, which is Swelliog, and we are working towards relocating some high volume, low complexity cases from St. George's Hospital. That might be a gynecology fibroid, that might be a gallbladder, that might be a hernia, that might be a basic breast surgical case, and take that to Epsom. How do we achieve that? We achieve that by generating capacity in Epsom. And we're doing that. You will have seen some colorful slides on with little boxes, and we are currently working in our strategy work plan to build a procedure suite, which means that we can take local anesthetic procedures out of the main theatre and generate capacity to come and invite surgeons and their teams and their patients to utilize the Epsom capacity that we have. We have 14 theatres in Epsom with day surgery, short stay surgery, and obviously Swelliog as well. And in Swelliog, it's worked like that already for a long time. So that is the development of Epsom Hospital as an elective surgery hub for ENT, gynae, general surgery, colorectal cancer surgery, and urological surgery. All of that is already in operation. Over the last few years, since I've been the Divisional Medical Director for Surgery, we have joint appointed many colleagues, surgeons, anaesthetists. We are already sharing job plans across site, and surgeons are familiar with traveling, including their trainees, to give the best care in the best environment. This means for St. George's that if a patient is on the waiting list with a St. George's surgeon, and they get cancelled and cancelled again because there's different priorities at St. George's. You know, they have major trauma, they have major children's, they have major cardiac, and patients get cancelled quite a lot of time, and facilities are not as good. So if we take these elective patients down to Epsom, they will have a better experience, a scheduled time of surgery, a short stay experience, and they will then travel back. It doesn't mean that they have to travel down to Epsom for any pre-ops. They will still see their surgeon at St. George's or at St. Helier, or at, you know, where they come from their base hospitals, and they will have their surgery scheduled on our EPR, which is now spanning all organizations and all sites, and they will just come for the day and they'll go back home, and the follow-up will be local. We were cutting down on follow-ups as well. You know, we are obviously leading in London with our PFO rates and our discharge rates, and that makes it better. We relocating a lot of follow-up. This might be a bit controversial to our GPs, but we're relocating a lot of follow-up into the community as well, and so that will help. With regard to St. Helier, and you will not hear me mention the new hospital. We all want the new hospital. There's no doubt about it. But there is obviously financial restraints and timing issues and everything else. St. Helier is a special place. It delivers really good quality DGH style trauma and emergency and children's emergency and children's elective surgery. And it has a fantastic hip fracture unit. Over the last 22 years, the hip fracture unit at St. Helier has been gone from strength to strength. Our length of stay is gradually now coming down. We have a re-enablement wards. We have a dedicated perioperative team. We have care of the elderly, frailty in reach, all of that. And we feel that if we were to take some, not all, but most of the hip fracture patients that are currently presenting to St. George's Hospital and waiting for a long time because other trauma takes priority, if we took them, they would reach the same standard as our patients at the moment. Our patients come in, they all have their surgery within 24 hours. No fail. and this is one of the standards, they all get mobilized out of bed the very next day. Our mortality is below expected mortality for that age range. And our general morbidity and complication rate is extremely low, which is reflected in the best practice tariff that we are getting. If you say, well, how can you accommodate at St. Helier? We can, because we will make it possible. We are only talking about 2 to 2.5 patients a week. A lot of bone protective medicine, which is being employed now for the elderly patients, has already taken effect. And where we saw 660 hip fracture patients only 4 years ago, we now have 430. So that a contrast with St. George's, where currently we have 210 patients a year. And we expect this also to 210 divided by, you do the math yourself, but some of the hip fracture patients presenting to St. George's are obviously multiply injured, have other requests and demands, etc., comorbidities, that mandates that they stay at St. George's. But the majority of the general silver trauma hip fracture patients will be well accommodated at St. Helier. So that's our second point. The third point is robotic capacity, and you will have seen that we are very proud to have a new robot, a Da Vinci robot, Leonardo, we call him, in Theatre 5 at Epsom Hospital. And we introduced robotic surgery on the 17th of March this year. And it's been safely introduced, and it is part of the Epsom, St. Helier and George's Robotic Governance Group. And we are waiting for the first 4 months of audit data at the moment, but I am not cited, and I would know of any complications. And Richard will be very pleased to hear that, because it's very close to his heart. I know that. So this is great. And if you look on the last slide as to where we are now and where we want to be in 2030, we're going to have more robots. We've got 2 at Swelliok, we've got 2 at St. George's, we've got 1 at Epsom. Robotic surgery, I'm not saying it's better than everything else. It still is the surgical procedure, and it depends on the surgeon, the anaesthetist, the multidisciplinary team. But it is the future. We can't get away from it. It will attract talent, it will attract consultants, it will attract patients, it will attract private work as well, at all of that. And that's really what we see. I've forgotten one little bit because I can't really see the slides. I've just been talking. We talked about procedure rooms, we talked about robotics, Epsom. Yeah, we've covered everything. So I'm happy to take questions. So thank you.
Brilliant, Andrea. That's fabulous. Thank you very much. Let me open it up for comments, questions. Andrew, Pankaj, Leonie, then Matt.
Thanks, Andrew. That was really helpful. And I think the idea of making sure each site is outstanding at what it does and focused on particular tranche of activity makes complete sense. The bit for me that I would perhaps like to see strengthened in the strategy is the focus on quality. So I think there's an assumption that by consolidating services you increase quality, which it can do, but it's the restructuring doesn't do that by itself. When you think about safety, patient experience, clinical effectiveness, I think this could be a key enabler for that. But I wonder if there's more we could bring out in the strategy in terms of some of the basics we would do to enhance quality and safety as we improve our approach, as we improve surgery, basically, because it won't just be the moving things around. There'll be a lot of things we need to do as part of that will help improve quality, and also the strategy is quite focused on the procedures and what you would do where. It does reference the sort of workup before surgery and the rehab afterwards, but that seems to me such an important element of patient journey experience and outcomes. I wonder if there could be a bit more as well as part of the strategy, how we're going to really prepare patients as well as possible for surgery and support them afterwards. So it's sort of in there, but in terms of emphasis, there's an awful lot on the moving things around. I'd like to see a little bit more on the quality agenda.
Okay. I would just like to mention one thing. So obviously we work as a group in terms of quality. Quality is at the foremost of everything we do. In the surgery strategy and standards group, we specifically look at standards, at quality standards, outcome standards, patient safety standards, and where we have identified with hospital metrics, model hospital metrics and GIRF metrics, where there's differences, that's where we focused our work plan on. And what came out, to give you an example, is there are some qualitative differences between our hospitals. Some gallbladder surgery, some hip fracture surgery, some gynae fibroid surgery. We are quite cited on that, and we're trying to address that. and by enabling the strategy to reflect that. But I also want to mention that we work as one organization when it comes to theatre safety and quality. We are just writing a paper together for the Quality and Commons Committee, and we are all working together, all theatres, all governance, all quality teams across Epsom, St Helier and St George's, because it is really all we think about. You know, it might not, a strategy is a strategy, you know, I understand what you're saying, but I will take it on board and we will discuss it with the team how we can make it a little bit more obvious. So, and with regard to the peri-operative care, I believe that care closer to home when it comes to things that can be done closer to home is the best. But if the best surgery for the patient takes place 7 miles down the road, so that should be the case.
Great, thank you, Leonie.
Thank you very much. Oh, sorry.
Oh, sorry. Go ahead.
Sorry,
Prakash.
yeah, thank you very much, Andrew. That's very interesting. I mean, building on Andrew's point, I mean, 2-3 questions. Firstly, where do we think we're going to get best practices incorporated here? Are we looking outside at other organizations who are doing things which is leading edge, or are we just looking at what's already in place and trying to make the best of that? That's the first question. The second question is, as we start building the benefits realization for this, and you think about how we're going to measure what's worked and what we're getting from it, are we just going to get the patient benefits that you've discussed coming through, or are there going to be other pieces? And the third, probably the most difficult thing in a way, when you implement a strategy, there's an assumption that everybody would buy into it and agree to everything you're saying. Where do you think are going to be some of the realistic challenges as you go to implement this?
So I start with your last question first. Absolutely, lots of antibodies, lots of challenges, lots of communication, and so currently we're trying to socialize, popularize the strategy by going to all the leadership groups, by talking to people about it. But to give you an example for the hip fracture treatment, there's definitely some work that we have to do, with particularly with the medical teams, the frailty teams, the orthogeriatric team, the length of stay, and etc. etc. So there are definite challenges, but we have just started to. So I'm the strategic chair, but there is a separate group to the strategy, which is the ops group, and that's been led also by Tara. She could probably answer this a little bit better, but the detail will be bottomed out. And where do we get our benchmarks from? We get our benchmarks from national data. We get it from Gov data. We get it from model hospital data. We get it from our own audit outcomes. We are quite cited on when things do not go well. You might know. So I'm chairing a group in gesh, which is called New and Novel. We're looking at procedures, surgery procedures, interventional procedures, invasive procedures. We make sure that we have the best evidence, the best NICE guidance, the best experience, all based on Royal College of Surgeons guidelines. And all of these guidelines fit in together. My boss is Carolyn Johnson. She is an anaesthetist, and she is the chair of all the CSSGs. She is particularly focused on finding variation, quality, diminished quality, and differences between sites. And we are also focused on inequality of health access. And to give you an example for that, we feel that currently there is inequality for gynecological patients at St. George's, and they might be of ethnic minorities. We just talked about it in the CSSG yesterday. If we enable the strategy, then those patients with their large fibroids and their large benign conditions, still really suffering conditions, won't have to wait as long. They will come down and they will be operated either robotically or open. And that's just one example.
Leonie.
Andrea, thank you for this strategy. I think it's fantastic that you've been brave enough to do things that will upset surgeons in terms of moving sites, because I know I've been there myself in the past and I know how hard that is. The one little bit I wanted to challenge you on was the robotic assisted surgery. You acknowledge that robotic surgery is expensive and we're not going to have 10 robots overnight. So it would be, and it goes really to Andrew's comment about safety, and also something we've talked about today about making sure that patients really are MDT discussed. So really to change the focus of that so that we're really talking about making sure patients get the best available operation, because one of the things I'm not sure about is whether we're doing absolutely everything as laparoscopically assisted, for example, and that should really be number one, and then we get on to doing robotic surgery. So it's really making sure overall that we're doing absolutely the best operation MDT and guideline driven that we can have, and I think that's really should be the focus, with laparoscopic and robotic being part of that. So my challenge.
I couldn't agree more. So the focus of our governance process for the RAS, robotic assisted surgery group, across gesh is absolutely that point. Just because it can be done robotically doesn't mean it has to be done robotically. And when people start fiddling around with things that open or laparoscopically only take 15 minutes, and suddenly they're £1,000 more expensive and they take an hour 15. So we really are on it. You know, we have got chairs, surgical lead chairs for each specialty: ENT, gynae, colorectal, upper GI, and urology. And each of them reports to, well, not to us, to me as our group, and ultimately to our medical director, because we need to be sure that the patients do go through an MDT. We're currently revamping our complete MDT approach, and we have already gathered all the evidence of which MDTs are we running, how are they being documented, how are patients being put through it. It is totally on our focus of mind. And I think I'm particularly cited on the costs at the moment. So since we started a robot, we have incurred an extra 45k a month of cost pressures, which we didn't foresee. Now, if you translate that against the procedure that we have done, there might be a good reason for it, and we are also still bedding in. But there is a consideration, and we can't be wasteful, you know. So we definitely, MDT is mandatory, almost for all, well, for all robotic cases anyway. So is training and ongoing training and revalidation of training. I give you an example. A surgeon wanted to do a private gynae procedure on the robot at Epsom on Saturday, and I had to stop it on Friday because I was not cited on that surgeon's portfolio, on their training sign-off, on their experience in the NHS. They said, "Oh, I'm fine, I've done it privately." So we can't have that. We are very tight on it. You know, we have a weekly robotic steering group. We have MDTs every week in all surgical specialties. That's just good surgical practice. And in fact, none of my colleagues would be wanting to take anything big to theatres without having relied on an MDT. It's just not safe anymore. You know, you can't defend yourself.
Matt.
Yeah, really delighted to hear that. Actually, the same standards of care and MDT for private patients and NHS, because it's not the same in the private sector in terms of MDT configuration, and we've got to hold a bar, whatever the patient type or payer. That's exactly what we'll do. Mine's not a question, it's a comment. I love your enthusiasm. And I think we need clinical leaders to put themselves forward and to work as a collective. And I think you give a great example because of how we can come together as a group, and you really get the benefits of a group doing this kind of thing, because you've achieved the sweet spot of everyone having a bit of an identity, playing into the strengths of what they do well, changing the working arrangements in the process, which will benefit patients, but also it will start to blur the lines between our hospitals. And I think we talk about cultural change. Well, there's top-down programs, but there is practical things that we do, such as this, which will start to change working arrangements. The other thing I think is around the blurring the boundaries of employment. So there's something around how do we get more joint contracts, and that's by default now. So rather than individual hospitals making an employment decision, and in every contract we're getting, you could work across any of our sites as a standard, which I think is also an enabler and sets an expectation, because it's hard to do it in retrospect. The last point I'll make is just really backing you up on the clinical outcomes and standards, because centres of hip fracture excellence are well known. They're very girth driven. We know that 50% of patients, that was the stat, it may be better now, but will pass away after 2 years if you're an elderly patient with a fracture. And early operation is actually a huge quality measure and an outcome measure of a service. And so you're basing your change based on nationally defined statistics, which are research based. And that's the strongest model we can put in place. So well done. I think it's really good.
Thank you.
And Bidesh.
Thank you. Andrea, thank you very much. It's really exciting, and someone who doesn't come from a medical background, it's really compelling, and I can see that focus on improvement in performance, and you sort of reinforce the quality pieces as well. I think my question is more directed to the executive, but you may have views. And one thing that wasn't clear to me was whether this turns into a plan which is about doing more with less resources, more with the same resources, or more with more resources. And then it made me think, how do we think about return on investment? And then as our different strategies mature, how are we going to prioritize? Sorry.
Michael, isn't this your area of expertise?
I think there was a productivity question at the beginning, which is probably easier. And I think it's answered in the slide where you've got that cascade down to the procedure suites. And so what they're saying is we want to use our assets on the right activity. And actually where patients don't need a lot of assets around them, then let's avoid that. And that's the cascade to the procedure suites. And that liberates capacity for the right things, particularly at St George's. So certainly, I don't know if it goes as far as more with less, but certainly more with the same. You'll notice in the cover sheet, it does talk about the modelling that's required and the finances. When we had a private session on this, we talked about we got a bit more into the finances behind it. Obviously, there's a capital requirement, so all of that's being worked through at the moment about what's this really going to mean for us and the best way to do it. What was the nature of your second point about prioritisation to link to that?
I suppose
first?
In the end, the group has finite resources with complexity around flowing to. Very sorry. So the group has finite resources. There's complexity about access to investment, and we have, I guess, different elements of strategy maturing at different times. And but even when they mature at the same time, there are choices you're going to have to make. And I'm crudely describing that as return on investment, but that's not just financial. That's whatever the return is that we're after. How are we going to prioritize all of this?
So I think it'd be really interesting to say, right, of all the different opportunities we have around how we spend money, which ones of those are going to improve either quality of life or mortality rates. And if you made investment decisions through only that lens, what would it lead to? And as a hospital, really, we should be doing a lot of that. But often the first question we ask ourselves is it affordable? Is it cost neutral? Is it going to save us money? But actually, there would be a completely different way of investing money if you invested in what I've just said. And then I think that would give you the ROI, because if you're improving morbidity or mortality, you're going to get less people, hopefully, in hospital, which hopefully saves you bed days, and there's a secondary byproduct of that. In this case, you're saying there's a length of stay benefit because ultimately St Heliers treats hip fractures because it sees more of them, and the pathway you've got is more efficient, and we should be able to count the bed days saved, which will either lead to bed closures, which I suspect it won't in this case. I suspect it will lead to the same resources, but seeing just more patients in that unit timeline. So I think it's a really interesting way of how do we as a hospital, with our prime goal to help the health of the nation, how do we really prioritise our investments? And of all the choices we have in our capital programme every year, do we really flag the ones that can add the greatest good to the population? And the answer is I don't think we really do that in that way. So it's interesting. I haven't got the answers to it, but maybe there's a different way we could do it.
Okay. Andrea, you arrived at a point in the day in a hot room and a long meeting where it would be possible for energy levels to sag, and you really pepped us up. So thank you very much.
Thank you.
We're thrilled to approve the strategy. Would you like the final word?
No, I thank you very much. We have been here before in December 24 with Jacqueline and Gillian, and we had to refine things, and things we refine and develop as we go as well. The basic thought is what we presented today, but there will be challenges along the way. There will be slight modifications. There will be some give-ins to financial restraints for sure, but we know this is the right way to go. This is the right way to go by our patients. We have 2.1 million surgical patients on waiting list at the moment. I mean, we might be doing a little bit better in Southwest London compared to elsewhere, but that's not to say that we are brilliant. And if you look at all these pathways, and do not forget, and I didn't mention that very much, we are working with the pre and peri-operative pathway, particularly with the new patient portal, the AI, optimizing patients, avoiding cancellations on the day, making sure they're in their best possible health, driven by primary care, and our collaboration with primary care. And I can see that this will help with us treating our patients quicker, better, more effective, and with less complications. I just know it, because I see it how it's been done at Sveliog, and we are going to copy that. Yes.
Brilliant.
Yeah.
Thank you very much indeed. So we're going to move on now to the group digital and data strategy. Welcome, Mark. Let us see if we can find you. Actually, maybe you could take over the mic that Andres just vacated. We've had previous discussions along the way in the development of the strategy. It's been reviewed and endorsed by Infrastructure Committee. Mark, would you like to? Is there anything you'd like to say before we get into a discussion? I'll give the floor to you and then to Michael. But please go ahead.
Okay, thank you. I obviously taken that everyone's read the strategy. There was a few points that I wanted to raise, a few brief points, just key takeaways from the strategy. But the first thing that I really wanted to say is that the strategy has been the result of the development of the strategy has been the result of some extensive engagement work across clinical, operational, and corporate teams. It's aligned to transformational priorities and it supports our move towards a merged, integrated health organisation. Strategy is also aligned with the recently developed 12-month digital roadmap, and you will see that between the 6 pillars that are in the strategy. The strategy's and it's positioned digital and data as a key enabler for safer and more integrated and increased productivity across the group. And just to also let you know that we're working really closely with our colleagues in the communication team to develop a communication strategy and a strategy on a page version of this as well, so it's more accessible going forward. Second point that I'd like to raise is around addressing risk and laying the foundations for the future. So it's made quite clear in the strategy that the current digital environment at gesh is quite fragmented and quite complex, and it does present some operational risk, and the strategy focuses on stabilizing and securing our digital foundations and creating the conditions for us actually being able to improve productivity, do advanced analytics, and have a responsible adoption of AI across the group. Third point is around having a clear roadmap. So the strategy, as you'll see, would been arranged or organised around 6 priority areas, and they are aligned to the roadmap, the digital roadmap that we've put in place for the year 26-27. In terms of how we'll stabilise digital gesh, priorities are intentionally focused on the areas where we expect to see the greatest organisational impact. So that's around NHS app, AI, data, EPR optimisation, and importantly, infrastructure modernisation. And the final point is around the outcome for our staff and patients. So for our patients, we believe that this strategy represents safer care, better access, and a simplified digital front door to our services via the NHS app. For our staff, we believe it means they'll have more reliable systems, reduced administrative burden, and more time to focus on care. And for the wider organisation, we feel that it means we'll have improved resilience, productivity, and just generally improving our readiness to move to being a fully integrated, merged organisation. Thank you.
Brilliant, thank you. Michael, anything to add?
Well, first off, a big thank you publicly, Mark, for your leadership. This was well in development when you arrived, and you've made a massive difference to it as well. So I really appreciate that. And one thing that I think is really important, and it does play out in the strategy, is that we have a real juxtaposition here about the opportunity that technology brings being amazing, and the fact nothing works, and people hate that. And I've just done a visit, and I've had another workstation on wheels plugged in because the battery life's not very long. The chairman's battery life on his laptop's 10 minutes. So I think it does a good.
That's deliberate, though. That's
yeah. I think it does a good job of acknowledging that we require investment at the foundational layer, at the same time as pioneering the really great stuff. And I think this strategy is trying to get a balance between the two, most importantly, because I think we do need to acknowledge that your average member of staff on a ward will say they struggle. And Mark's done a brilliant job. So very recently, he's been sending out teams to problem find and problem sort, as well as AVT with the Secretary of State visit. So there's a really nice balance between the two.
Great. Let's open it up for discussion, questions, comments. Claire first, and Andrew Pankaj.
Yeah, obviously from an infrastructure committee perspective, we've gone through this in depth. We touched on it earlier. I think the one thing I would really emphasise is this is foundational to everything we want to do, as a trust. Increasingly, technology is the foundational enabler of all work. And we're not going to be able to do what we need to do without the kind of fundamental remediation and accelerated pathway that Mark's identified as part of this strategy. You know, we can't build a new hospital without foundations. We can't be the trust we want to be without this digital foundation.
Very good, Andrew.
I think it's really good, and the priorities look like the right ones. And I suspect that's partly because, as you reference, you've done quite a lot of engagement with staff to develop these priorities. My question is, as you then start to work through the solutions and post-implementation, evaluate and tweak what you've done, what's the plan for really continuing to engage with staff and with the digital front door with patients to make sure we get it really right?
Would you like to respond to that, and then we'll come on to the others? Yeah, please.
So I think we've already started that, and we've started it quite early because we want to benchmark and have an understanding of where we currently are. But we recently completed a digital experience survey for the whole of gesh. We've had the results back in. I've seen them. I've analysed the results with the team, and we'll do that every year. I think that's really a really important thing, because we can see when we've delivered projects, we can see when we've done a lights on implementation, but what that will help us to do is to understand the effectiveness of some of the things that we're doing, because many of the things I'm seeing highlighted there, many of the difficulties that people have highlighted around the table, or say when we go on ward rounds as well, which will continue across all of the sites. So I think that's going to be quite an important thing for carrying on that engagement, to ensure that we're getting the right balance between fixing some of the basics and understanding whether the investment we've put in is sufficient, or whether how we've used the investment is sufficient, and where we need to focus on next.
Thank you, Mark. Pankaj.
Well, thank you very much, Mark. It's a great to get a kind of like a timeline and a storyline. We tried to implement a similar plan at a previous trust where I was working, and what we found, and I'd like to understand if it's the same challenge here. The NHS application landscape is so complicated and it's mismatched, and it's been built up over a number of years without any kind of integration. So the assumption was that we'd fix the foundation, but what really happened was fixing the foundation took a very long time. And all the other things, like Claire said, building up on it was not easy to do, because it was bugbears was just fixing things and getting to that level. So do you think that's an area where we will have some challenges? Because not only integration and improvement, also you have to retire and decommission a lot of systems, and that there's a lot of change with that. The second question I have is probably more for Michael. If you look at the transformation programs, they all have things like your digitally enabled solutions and AI. So how does that fit in with this plan? Because if we're going to be implementing AI in 28 and somebody wants to do it next year, how do we fit that together? So it's a two-part question.
Why don't you start, and then we'll give Michael a chance.
Oh, sorry. Yeah, thank you for that question. In terms of what you've highlighted, I think that will be particularly an issue in terms of the system landscape for gesh, because there are two organisations come together. I've already identified there are quite a few areas where we've got duplicates of things. Not only that, there are wider issues across the whole NHS in terms of interoperability, in terms of how the systems talk to one another. We've got, in terms of our plan, that's quite key. You would see on the more detailed 26-27 digital plan, we've made provision to look at how we can address some of those interoperability challenges. About a month ago, we had the first of a workshop session where we brought together not just senior people, key operational, clinical and digital people across the organisation to look at how we can optimise our electronic patient record. We know there's a lot of work to do there. That's a key area, because if we can get that right, that will help us simplify some of the landscape in terms of having systems that do things that could be better integrated into our EPR. And we know we haven't got things right in terms of the way it's configured at the moment. So that's something we're putting a lot of focus and a lot of energy on, but we're not waiting for one thing to finish and then start the next thing. And you mentioned AI in 28, but we are doing AI now. So we're going to be piloting Copilot this year, or doing some work with Copilot. We're going to do doing some work with agents. There's the work to set up and establish a digital centre for excellence, which will be quite focused on AI and automation.
Great, Michael.
Yeah, I'd probably build on that. Thanks, Mark. That to your point about strategy development in other areas and dependencies. So in finalising this, Mark has met with each transformation scheme to try and understand, am I playing to the right things? We've also done some dependency mapping to understand which functions are going to be feasted upon the most. And as you would expect, digital and data is one of those that really stands out. The bit that's going to make this more doable, I think, is Mark's drive to simplify and standardise things, because then more people can enjoy the assets of AI easily, where as opposed to different applications for different things not speaking to one another and taking up a lot of valuable IT resource.
So that means we're going to have to put in a very centralised control and governance
Yes.
framework to make sure nothing can happen without going through your organisation.
That's very true, and I've recently taken a paper through our local governance to look at how we restructure slightly some of our digital governance, because it's done a good job up until now, but I think it's about to get a lot more complicated, and I think we need some extra support. So that's something Michael's reviewing.
Okay, great. Yin.
Yeah, thank you. I was really pleased to see references to accessible digital services and the provision of alternative routes to those who need them. I suppose my question is, how would you ensure that alternative routes are given to the people who do need them, so that there's no falling through the cracks caused by digital poverty?
Can you press the mic, Mark, please?
You forget. So I think there are two parts to that question. So the first part is that if we are making a route into the organisation, or a route in available by the NHS app, we also have to bear in mind that some people won't use it, so there has to be the option not to use the NHS app. But one of the things, because we've recently been working with NHS England on becoming a digital exemplar for portal development across southwest London, well actually across London I suppose, so one of the things that I am thinking is that we get a lot of investment in from NHS England, or from people that are funding us, to look at getting the system implemented, doing a lot of the business analysis and the change piece. But I think we could be missing a trick, and I fed back to NHS England, because what we don't seem to be invested in is some of the resources to actually maybe put them into clinical areas, or maybe we can focus those resources perhaps outside of the hospital and community settings to help people to get up to speed with the NHS app or various apps. I think there is a piece of work to do there, because there are many people that simply don't want to use digital means to interact with us, but there are a lot that do but haven't got the confidence to do so. So I think some of that investment should be channeled towards that, and NHS England seem quite keen, and it's something that I'll keep pushing on.
Okay, thank you very much indeed, Mark. I think, looking around the room, we're all very happy to approve the strategy. So thank you to you and your team for all the work on it, and we look forward to the execution delivery phase of life. Thank you very much. We're going to move on to the group board assurance frameworks. Steve.
Yeah, so we've touched on a number of the individual strategic risks on the BAF during the course of the committee feedback, so I wasn't going to touch much on the individual risks, but just wanted to sort of frame some of it. So the board, the BAF ultimately is about the principal risk to the delivery of our strategy. We agreed a BAF as a board back in early 2024, linked to the new strategy. But earlier this year, the board took stock of the big changes that have happened in our external environment particularly with the structural changes in the NHS, the 10-year plan, the changing financial climate, and internally our own medium-term plan and our transformation programme, to say we need to take stock of the BAF. Is it still the right representation of the strategic risks that we face? And we agreed that we would refresh the BAF, streamline the number of strategic risks we had. We had 14 before. We agreed that we would streamline that to 10. We've actually got 9 here, and I'll come back to that in a tick. Particularly to make sure that we had a clearer view of the big strategic risks facing us, and to tie the BAF more explicitly towards that transformation programme, the delivery of which is absolutely key to the delivery of the strategy. So what's in the pack is 9 strategic risks, 8 of which are overseen by the committees of the board, and you've heard the committee's feedback on those today. And then one of them, the risk around the delivery of transformation, reserved to the board because the delivery of the transformation programme is cross-cutting. So just a word about the development of the BAF. So since we agreed on the need for refreshing it, we've gone through a process of developing the new strategic risk with the board steers from earlier this year. That's gone through the Group Exec Committee. The individual risks, with the exception of the Transformation one, have gone through the relevant committees of the board, and the Transformation one is here today. The key things I would highlight, so we've got, in terms of risk scores, we've got one risk, the finance risk, scored at the maximum 25. The biggest chunk of them are scored, 6 of them are scored at 20, and then 1 at 16, 1 at 12, the lowest one being our research one, but that's not to take away from the strategic significance of that. Then across the 9 strategic risks, 7 are rated as partial assurance, where I think the board and the board committees can take some level of assurance about where we are, and then 2 are more limited. And I think stepping back from that, one of the key reflections is across a lot of what we've done, we've got strategies in place, and we've just discussed some of those. We've got governance processes in place, but particularly when you look to things like transformation, some of those are in the early stages of maturity, and hence the assurance rating is lower, but we expect to come up. So typically the board has set a time horizon for setting target strategic risks in terms of what we expect to happen in terms of lowering the strategic risk score and increasing the assurance rating. Because we're introducing this partway through the year, we've set a time horizon of March 28, which felt more realistic, and the paper sets out where the committees of the board feel is realistic to get to in that time horizon. And we've touched on, for example, on estates, the fact that, and likewise on quality at times, some of the risks we may not be able to mitigate the actual risk score, but we should be able to build up the assurance level as we see some of our issues work through in more detail. So the final thing I wanted to say, without focusing on the individual risks, is this should be a key driver of how we take forward our business as a board. It should be what helps shape our agenda. So I think the key thing for us now, as we hopefully agree this new BAF, is how we then use it going forward. So we're going to come back to this on a quarterly basis, and the paper sets out how we'll do that. But it really should be quite a key document that allows us to plot early intervention, to focus our assurance conversations, and to really help support prioritisation. So that's where we need to get right. You'll see from some of the actions that are in here that some of them need a further bit of iteration. There are some actions where the actions are TBC, and those need to be worked through with some of the executive leads. Because as Badesh was saying earlier in the meeting, what we need on each of these is a path to green, or a path to get to the target risk score. So there's a little bit of further refining that we need to do, but I might leave it there.
Great, thank you very much, Steve. Comments, questions? This has almost all been through committees. Great, so we're happy to approve all that. Thank you very much indeed.
Sorry, Mark, just a point of clarification. So the numbering has changed, hasn't it? So when we were talking in committee about SR 6 and 8 for quality committee, it's now 5 and 7.
That's right. So
just wanted to get that clear for the
bit I
notes.
didn't. Yes,
good spot.
So
yeah, thank you, Andrew.
the bit I didn't come back to was the fact that when we talked about redefining the BAF earlier this year, we did talk about a left shift risk. One of the things as an executive team we talked through, and we touched on it again earlier today, about to some degree the lack of national clarity, and then some ways internally the degree to which we need to work through our internal strategic direction in terms of the left shift before we can define what is a meaningful strategic risk on the BAF. So we are hoping to bring that back during the course of the year, but you're right, because we don't have that 10th one, the numbering does change slightly.
Very good. Thank you very much. Do you think we've identified any new risks and issues? I'm not sure we have, honestly. Reflections on the meeting. I often we've asked someone in advance to think about this during the course of the meeting, which we haven't done this time. So, is there anybody who'd like to offer any reflections on the meeting? I know it's been a long meeting. Bidesh, yeah.
I mean, I've really actually enjoyed the meeting, and I think the discussion has been a good discussion. One little bugbear is the paperwork was massive, and the thing is that I mean, it does represent a lot of work that a lot of colleagues have put in, but it actually makes governance hard because it's really hard to get your head around so much. So a plea to recognise that.
Okay, let me just mention one thing, a vehicle we have for picking that up. When I was interviewed for this role 18 months or so ago and asked, you know, were there things that I'd seen in my discovery process that maybe we could address? One of the things I talked about was the desirability from time to time of an external review on board effectiveness, governance effectiveness. We do a good job every year internally to look at that, but since the group was created, we haven't had an external look at our governance. And so I have, as a chair's action, with the help of Andrew and Yin, and also checking out a couple of personality issues with Leonie, and with also some input from Matt and Michael, put in place an arrangement where we will have a review externally, which Steve has helped with this as well, later in the year. And one of the things we put in the terms of reference, which I'll circulate shortly, is exactly that issue, because too much paper can get in the way of proper accountability and performance management. So I'll circulate a note with a bit more detail on it, but I completely agree, Bidesh. It's not an easy problem to solve, actually, but we need to do better than we're doing at the moment. So thank you for flagging that, and I will follow that up by sending something round. Any other reflections, Andrew?
I'll give you one reflection. I mean, I thought it's been a really good meeting. The fact that my energy level is still reasonably high at this time of the afternoon is quite. It shows that we've been talking about really important things, and it feels like challenging questioning is welcomed. And I think the culture we're creating here is really healthy. One question is around the committee reports, and I was slightly thrown because we say they're for noting, but then we're also trying to give an assurance rating on the committee report, and I wonder what we want to do with that, whether we just note them, because it's quite hard, for example, for quality committee to say how assured I feel about the overall all the range of issues we look at, and I just wonder whether we want to try and say how assured we are, or whether we just note it and we leave the assurance for the committees.
I think that's a great point, and actually the cover sheets complicated a bit today how I've tried to manage the meeting. So let's take that away and have a conversation about it. I slightly tend to the view, given what you said, we should note rather than debate further. But let's take it away. Pankaj.
Yeah, I mean, just supporting colleagues. It's been a very, very interesting meeting, but the reflection, it's kind of almost like a snowball that's going down the mountain every time we have meetings. Like you kind of realise, and it dawns on you that we're doing a great job on the day-to-day delivery. There are a lot of challenges, but I was really, really energised by all the successes that were there. And we are. I mean, I've got personal experience of how we're doing very well. But it dawns on me more and more that the same people are trying to do more and more and more. And how do we create space? Because physically it's not going to be possible for the few to do everything. And it's a challenge. It's not anything. And I think Matt's point, I think that captured it. There are some risks we'll just have to live with. But as I say, to me, maybe you may have a different perspective. It feels like the ball just keeps on getting bigger. Nothing's kind of getting off the agenda.
Yeah. Yin?
really small point, but we didn't have a patient story today, and I suppose
We're
it was-
about to.
Oh, okay, right.
Vic?
Yeah, I just wanted to reflect on the conversation about our ILD patients, and I just wanted to say that whilst I think we can be hugely proud of how we've responded to that, including in this meeting, I mean, no patient should be harmed, right? And I think that we need to reflect that that was a very serious situation, and that as a board we are accountable to our patients. And yeah, I'm glad we've been able to discuss it in public. But I think that that is the takeaway that I will take from this meeting.
Thank you. Okay. We've not had any questions sent in advance from members of the public. Governors were here earlier. Most have had to go, but we do have a protocol which allows governors here at the end of the meeting to ask anything they'd like to ask. Dimpner, is there anything? No. Okay, great. Thank you. Thank you for coming and being part of the meeting. I've not been alerted to any other business, which means there is no other business. And now we're going to have the patient story. So can we welcome Savio and Rose? Let's find you, yes, by Nicola, somewhere to sit with a microphone. I think, Nicola, you're going to say something by way of introduction. Is that?
Thanks very much. So it's just to introduce Rose, who is one of the clinical nurse specialists. They work here at Queen Mary's Roehampton, and I think this is quite fitting with the surgical strategy. And I think I'm not going to say anything else, because I think what you've got to say is far more important than what I've got to say. But I think what you'll see is the excellent care that gets given up here. Over to you, Rose.
Hi, I'm Rose Southby, lead urology nurse. I work across George's and Queen Mary's. Been working here today. It's a great site to work. This is Savio, our patient, who will tell you about his experience. I was asked just to very briefly outline our prostate cancer pathway, which is mostly delivered here at Queen Mary's by our nurse specialists and advanced clinical practitioners, and also to talk about how we've transformed our prostate biopsy lists. So just to sort of briefly outline, when our prostate patients are referred in, our 2-week wait referrals are triaged by our nurse specialists, and within a couple of days they go into a one-stop rapid clinic. This is also nurse-led, and on that day they have their MRI scan. They are then seen with the result a couple of hours later. They're given the results by the nurse specialists, and then if they need a biopsy, they are booked for the biopsy. We have recently, if we have capacity, actually seen the patient and biopsied them that day, and that may be something that we may be able to look more at going forward. So that's our one-stop rapid clinic. They're then listed for a biopsy. We have, in the last couple of years, completely transformed our local anaesthetic transperineal prostate biopsy service. So going back a couple of years, we were doing all of our biopsies in the theatres. Obviously, there's a lack of space in theatres. It's very expensive, and it was consultant-led. We collaborated with South West London Alliance, who had a project at that time. It was a diagnostic project, which was to train our CNSs and advanced clinical practitioners across the network. And George's led on the training. I was recruited as the practice educator. And we actually trained a nurse at Epsom, Croydon and Kingston. And we also trained a nurse here at George's. They are all now running their own lists, which is absolutely fabulous. Once we trained them, the sort of second phase was to start moving, well, particularly at George's, to move the service out of theatres. And about a year and a half ago, we started delivering the service up here at Queen Mary's in the clinical area just around the corner. So there's 2 of us that are doing the biopsies. We are obviously still supported by the consultants. They still do biopsies, but in general, we run the list from week to week. So I think that's been a great success. It's made a difference to our cancer targets, to the flexibility. It's obviously reduced costs as well for the trust, which is great. So it's been a great success story. Once they've had biopsies, they're given results. It's generally by the consultant, supported by the clinical nurse specialists. And then if anybody does opt for surgery, they will have the surgery. They then come back for a survivorship clinic. It's also nurse-led, where we monitor their PSAs. We talk to them about erectile function, so the side effects of surgery, and we also support them with any continence issues. And then we also have an erectile dysfunction clinic. So anybody that can't be managed within the survivorship clinic can be referred to our specialist erectile dysfunction clinic, again, which is run by our nurse specialists. So that's just a brief view, brief outline of our prostate cancer pathway. And Savio is now going to talk to us about his patient experience.
Okay. Good afternoon, everyone. Thank you for this opportunity to be here. It came as a real coincidence because I was in the throes of sending an email to my nurse specialist seniors to commend the service I was getting. So when I received the email last week, I thought, wow, I'll hold my horses, report back here, and probably still follow it up with the email if that's necessary for the particular individual. Okay, I must say on a light-hearted note, sitting out there took me back to my career in around central government, sitting in committees, chairing committees, running committees with ministers and heads of state, and so hearing these things sort of brought back memories to when I was last working 6 years ago when I retired. I'm going to be 71 now, so that's where I am. So it was interesting sitting here and hearing some of those and bringing back those memories. Right, so my experience, just to bring context to it, I was diagnosed last September with prostate cancer. It came completely out of the blue because I had no symptoms. My PSA was very low, 1.79. No symptoms, and the only fly in the ointment was my father had had that, and he died as a result of it. So obviously, with a low PSA and then having the MRI, I went there thinking this is going to be a doddle. My PSA is low, but I was told I had that. But nonetheless, you know, I took it, I faced it head on. But that was not least helped by the attitude of all the staff around from the relevant part of this urology department. That's just as an overall thing and bringing context to it. So if it's all right with you, I'd like to focus on all the positives. There are a few negatives that I want to bring to attention. In fact, another coincidence is on that particular negative aspect, I have raised something through PELS eventually about 5 weeks ago. And I said to them when they're writing to that service to explain to them that if they don't come back with any information, I will approach the chief executive because that doesn't stop me. Having dealt with heads of state, I mean, you know, nothing stops me. So, but 3 weeks later, when I accompanied my friend Dito's here to his trauma and orthopedic surgery appointment, I then stopped in there and she said to me, have you heard? I said, no. She was shocked. She sent back another email to her senior and saying, look, this is the case, you know, and so that's one thing that I will want to raise as well, because I think it's important to know.
Right.
Okay, so if I start with the positive, I'm going to focus first of all on my cancer specialist nurse who is called Sophia Hobson. I cannot rate her highly enough. I mean, her work and patient-focused ethos, her ethics are exemplary. She's exceptionally organized, responsive, proactive, professional, personable, practical, and appropriately reassuring. As such, she's an absolute asset to the unit. I've only met her senior today for the first time this afternoon, so that's probably the person I was going to email. Sorry to say that, but you're hearing this before I email you. Absolutely asset to this urology cancer unit at St. George's Hospital, as well as to the nursing and medical profession, and equally to all patients who she deals with, to the point where when she's dealing with me, I came although I had potentially aggressive cancer because it was about to burst and it was non-secreting, my PSA was non-secreting, it was not known. I came away, I believe, lightly, touch wood. I think I'm over the hill that no one knows with these things. But her undivided attention, and I'm sure she's dealing with loads of people at different levels who are in a much in quite serious, nasty situations. But when she's dealing with me, even though I'm kind of comfort lightly, it's as if there's no one else, and so that's something that's come through as well. So I really have to, commend her. She is what I was going to say, is she merits recognition as a rising star, deserves promotion, but any related transfers would be a loss to the unit, to the patients here. And the vast, there are vast numbers of rising prostate cancer cases. So, moving someone, and I don't know whether she wants to move to, elevate her position. But a possible alternative was, I was going to suggest, was maybe in the form of some sort of recognition, like either internally and or externally, including like an honours recommendation. And that's something that, I think the evidence will be available through the department in terms of her outputs and her outcomes and her results and things like that. But if there's anything else that you need from me, I can always support that. There are others also in the unit who I want to acknowledge with thanks and admiration. The professionalism, personableness of all the staff within the unit, not least Mr. Sri, my consultant. Kerry Smith, who is her counterpart specialist nurse, who was the one I only encountered once when she did my biopsies, along with two other female colleagues who were all, at the time, advice was being taken. They were highly professional, very humanly reassuring, and had great calming influences. So that's something I want to say, as well as Dr. Agarwal. When I was being admitted for my surgery, radical prostatectomy, robotic surgery, the lady was talking about here in one of the early agenda items, he went through everything. He was absolutely, good on that, ace on that as well. So those are all the positives that I want to say. There are some connected units as well that you deal with. So, for example, following prostate cancer surgery, there is unfortunately bladder incontinence. I've got over that completely, but there is, and so I was at my request, I was referred to someone in the specialized pelvic health physio section, someone called Emily Cowles, who I saw. She's truly amazing. She demonstrated very much the qualities and attributes that I've kind of rated out here for Sophia in terms of everything she was doing. Even though mine was fairly insignificant in the grand scheme of things, she was just totally absorbed. Her professional and professionalism, her knowledge, her personality, her reassuring, and she was very proactive. She came back. She came directly back. I mean, such qualities from associate units enhance the work also of the the cancer department, of urology department, unit of the department. So those are my positives that I want to say. I don't know if you've got any questions on that before I go on to the negatives.
Yes, please, Michael.
So we have the Gesh Awards, and patients can write award bids. I assume we've got yours. If we're not, if we've recorded this, we might just translate it into, particularly for Sophia, which stood out very strongly.
Okay. Thank you for that. So shall I just summarise that and send it to Rose?
Well,
you've got it
we'll work
recorded?
that out with you, the best way to do it. Yeah, we'll work that out with you,
All right, okay,
Savio,
fine.
the best way to do it. But that's a great idea. That's a great...
Okay, certainly.
Please come on to the how we can be better point.
Yeah.
This is. Can I just say this is Sophia?
Oh, hello, Sophia.
We've stopped talking about you.
And she has no idea what's just been said. so
Okay, and we won't tell you, Sophia, but it was all good. It was all good.
Oh, I'm shame you missed it. You'll have to listen to the recording.
So, Savio, please go on to the... It's great, the positives are great, but actually we're really interested in how we do better. So what you're about to say is really important to us.
Yeah, I can give some very specific examples and individuals as well. I mean, are you happy with that?
Please.
Okay, so the very first, when I was first referred to the urologist department, I saw I didn't make a note of her name, a female urologist who was very good. She did the DRE, which the referring doctor had done, who was a non-specialist, and thought nothing of concern, but maybe you need to be referred because of your father's history. She didn't identify the same thing, that she wasn't sure what the other person had seen. However, to her credit, she did refer me for an MRI, given my father's history, which is fine, perfect. The only thing is, from that appointment, I've never had any communication whatsoever to myself or my GP. So I think there's something, that's missing, that's been omitted. So I don't even know her name. I didn't make a note of it because I thought when I get the communication or when he goes to my GP, I'll know who it is. So I tend to remember everyone's names and things like that. So I had no, idea. So that's something that was lacking. Anyway, following the MRI, I then saw another urologist who I think, the person to give me the news, Mr. S.M. Adil Rahman. There were some inaccuracies, both in terms of what he told me. He told me there were only 2 areas. One was marginal, one was suspect. But when the thing came out, there were more areas, and so that was quite different to what I was told at the time. That said, he still referred me for the biopsies, which occurred a week later, which is fine. The other thing was, in his report to my GP, in terms of history, he gave history of past recordings of my PSA in the past, whether it was hospital or GPs or whatever. And there's a recording of 13 in October 2023. I've never been anywhere near there. I've always been in the region of one point something. So I don't know, that's a significant typo. If it's just a typo, fine, it's a typo, but it's still on medical records. It's not really, conducive or ideal. Yes. So that's one. Then I had my surgery on the Thursday, the 4th of December. On the Saturday, on Friday, I was transferred to Vernon Ward. And on the Saturday morning, I was discharged, having been seen by Mr. Shri and Dr. Agarwal. I was being discharged. The discharge nurse was very good. However, I was prescribed something called, so this is very technical, but it's because I thought Mr. Casey would be here as well, who I've never met. So tadalafil, to be taken twice a day, 10 mgs. The nurse said to me, "You've got to take 2 of these twice a week, not one twice a week." And he said, "And you start now." And he gave me the 2 to have. And so I did that on the Saturday, and on the Thursday I did the same thing. When coincidentally I was speaking with Sophia for other things, and she asked me, "Have you had, and you've been prescribed tadalafil?" I said, "Yeah." And she said, I said, "This is yes, and I've taken it already." And she said, "No, you're not supposed to take it until after your catheter is removed, which will be about like 2 weeks later. It's not supposed to be started before." Apart from which, I had like 4 times the dosage because I was wrongly informed. So I didn't. I will probably have his name. I looked up the discharge papers to see if I could find his name, but I couldn't find his name. Okay. But the records will show who discharged me and gave me the medication. Okay. That's again another error that really shouldn't have happened. Yeah. The third one I want to talk about is, and I think you mentioned that unit where you work with the erectile dysfunction unit. So I've been referred to someone called Roshin, R-O-I-S-I-N, Roshin it's pronounced, I believe. I had an appointment scheduled for April, around the 9th of April, and I got the dates here actually, 23rd of April. Shortly before that, I just got a letter saying it's been cancelled, 29th of June. So I thought, oh, okay, fine. I spoke with the main outpatient's number, appointments number, and they said something about probably in clinic or something like that. So I just accepted it. Then I got another letter saying 29th of June is cancelled, 25th of August. So this time I rang them and I asked them, I said, can you find out what the reason is? Because they couldn't tell me anything. They have to always refer to the unit who make the decisions, and they make the appointment dates and all that. So they couldn't tell me. They said, we'll escalate it. They use the word escalate generally, just as in we'll raise it. And so we'll escalate it. And if you don't, I said, if I don't hear, because I didn't hear anything last time as well, within 2 weeks, give us a call. So I rang back again, hadn't heard anything, we'll escalate it again. So I said, look, can you please tell them, I just want to know why these are being cancelled. I'm not trying to say I want it not cancelled. I want it yesterday. I just don't want it. Want to know the reason, the rationale. And so nothing came back. And then a week later, I said, please can they let me know as soon as possible. So a week later, I rang again, spoke with someone else. I've got all the details of the times and the records of who I spoke with. Okay. And And I said, look, can you tell them, look, if they don't come, I will raise a formal complaint. Anyway, the long and short was I subsequently, which I referred to at the start, I raised the complaint about 5 weeks ago with PALS. They followed it through, still nothing. They've sent another one 3 weeks later, nothing. And I did say to them, please, emphasize, as I said the first time and the second time, that I will raise it. If necessary, I will go to the chief executive. Nothing will stop me. So here I am, as it happens. But that is totally arrogant, I think, apart from anything else. Just they should actually give an explanation of what's going on, why. And now, of course, I've since had an explanation, another letter saying the 29th of August is cancelled indefinitely. That's because they've changed the procedures for booking things that far ahead within the unit in urology, or certain parts of urology. So at the moment, I'm in limbo, so those are the three real negatives that I must raise here.
Okay. Savio, thank you very much indeed. So the Chief Executive, Matt, is here. Kate, who runs the hospital, is here. Nicola, the Chief Nurse, is here. What I'm going to suggest actually is, because there's quite a lot of important detail you've given us there, which we would like to follow up. So I'm going to ask Nicola if she's got a few minutes just to sit down with you so we can capture all the information and we can get you a proper reply on all of those things. Thank you very much indeed for bringing them to us, because there's some things for us to understand and follow up, and we would like to do that. I'm good. Matt, would you let me?
Yeah, I mean, that's a bit rubbish, isn't it? I mean, you've had a big life, event. It's never, you've understood you've got a cancer, you've had the operation, and then you're trying to access care afterwards. So I am really sorry that's happened, and it's happening. If it's happening to you, it's happening to others as well, because it's often not a single thing that happens. It's a system problem. So let's see if we can sort that out and see if there is a systemic problem that we need to fix. But you shouldn't need to fight for your care. We should be able to plot it out for you, and you'd be certain of it. Sometimes cancellations happen because of sickness or other things that happen, but we should get it right, and we should have a conversation with you to explain it. So that's not a standard of care.
Yeah, it would take just a couple of minutes just to say what it is. Fine, I know.
Completely get it.
I have to say, sorry to interrupt you, but I want to say that it's crossed my mind. I thought, are they putting private patient surgery, because they do surgeries as well, using NHS facilities at the cost of cancelling operations? That's the other thing I wanted to say. My gut feeling is I know how these things work, so I have to say that outright.
Yeah. That's not the case.
No. Okay.
So I actually manage Roisin.
Oh, okay.
I was wondering whether I should just keep quiet at this stage.
Okay.
She runs a very good service, but it's a very specialised service, and at the moment she's the only nurse running it. So I can't answer at the moment why these ones were cancelled, but we have already started making a difference, training a second clinical nurse specialist to provide that service.
Sure.
So that will definitely improve in the future, because there's always a second person to step in if they're cancelled for any other reason. The other thing I can say is I know that there was an issue that we started a sacral nerve stimulation service in the urology team, and it had to move from Queen Mary's to George's, and the day changed, and Roisin supports that service. So actually she had to cancel some of her clinics to be able to support the other service that was moved to St George's. So I think that may be one of the reasons.
Well, that sounds highly like that might be the case then, because that was the first time I was told that there's something about having to be in another clinic, or in clinic. That's right. Those are the words that we used.
I'm happy to.
Yeah,
I'm
happy to. I think if the three of us will have 5 minutes at the end, we can dig into it a little bit. Yes.
Because what we want to do, Savio, is deal, as Matt has said, with all the kind of things that is not working for you, but also crucially we want to learn the lessons for other people. That's why we have the patient stories. It's really important to us to understand the things that were good, but also the things we need to get better. So I really, really want to thank you for coming here this afternoon, being totally transparent and open and honest with us, because that's what makes a great patient story and gives us a chance to improve, which is what we all want to do. Are there any other questions, if you don't mind me asking my colleagues? Anybody else wanted to ask anything? I do just want to say to Sophia, your 8 years must have been burning, because Savio, before you arrived, told us what a fantastic job you've done. So thank you and well done, and thank you very much indeed.
Thank you.
so that Nicola and Rose will follow up now, if that's okay. And otherwise, I think we have got to the end of the meeting. I hope you'll have a break over the next couple of months. We will be back on the 11th of September for the next group board meeting. And in the meantime, thank you all very much indeed. Oh, thank you.